ಅನಿಲ್, ಹಲೋ ಅನಿಲ್. ಅನಿಲ್, ಯೂಟ್ಯೂಬ್ ಲೈವ್ ಒಂದು 2:30 ಮಾಡೋಣ ಅಲ್ಲ? ಯೂಟ್ಯೂಬ್ ಲೈವ್ ಸದ್ಯಕ್ಕೆ ಒಂದ್ ಸ್ವಲ್ಪ ಬ್ಲಾಕ್ ಮಾಡಿದ್ವಿ. ಹಾ, ಲಿಂಕ್ ಓಪನ್ ಆಗಿದೆ ಸರ್, ಬನ್ನಿ ಝೂಮ್. ಬನ್ನಿ ಬನ್ನಿ. ಹಾ ನಿಖಿಲ್, ಅದೇ ಅದು ಡಾಕ್ಟರ್ ರಿಲೇಟಿವ್ ನ್ಯೂಕರ್ ಪಾಸಿಟಿವ್ ಬಂದಿದೆ. ಹಾ ಅನಿಲ್ ಹೇಳಿ. ಹಲೋ. ಬೇರೆನಾ? ಇದಲ್ವಾ, ಹಳೇದಲ್ವಾ? ಆಯ್ತು, ಇದನ್ ಕಳ್ಸು ಈಗ. ನಮಸ್ಕಾರ ಸರ್. ನಮಸ್ಕಾರ. ಸಕಲಾಗಿದ್ದೀರಿ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್. ಎಲ್ಲಿ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಇದ್ದೀರಾ? ಎಲ್ಲಿದ್ದೀರಾ? ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಇದ್ದೀರಾ? ಸರಿ. ಅನಿಲ್ ಏನೋ ಎಕ್ಸಿಟ್ ಆಗ್ಬಿಟ್ಟ, ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಆಯ್ತು ಅನ್ಸುತ್ತೆ. ಕರ್ನಾಟಕ ಸ್ಟ್ರೋಕ್ ಫೌಂಡೇಶನ್ ಇಂದ ಎಕ್ಸಿಟ್ ಆಗಿದ್ದಾನೆ. ಸೊ
ಅಲ್ಲ, ಅದು ಅನಿಲ್ ಅಂತ ಹೇಳ್ತೀರಾ ಮಧ್ಯ?
ಅದ್ರಲ್ಲಿ ಏನಿದೆ ಸರ್?
ಹೌದಾ?
ಅವನೇನು ಪ್ರಶಾಂತ್ ಹತ್ರ ಜೀತಕ್ಕೆ ಏನಿಲ್ವಲ್ಲ?
ಅಲ್ಲ, ಅವ್ನು ಪ್ರಶಾಂತ್ ಫೋನ್ ಮಾಡಿದ ನನಗೆ, ಎತ್ಲಿಲ್ಲ.
ಬಿಡಿ ಸರ್, ಅದೆಲ್ಲ ತಲೆ ಕೆಡ್ಸ್ಕೋಬಾರ್ದು. ಅನಿಲ್ ಏನ್ ಎಕ್ಸಿಟ್ ಆಗ್ಬಿಟ್ಟಾ? ಜಾಯಿನ್ ಆದ್ಮೇಲೆ ನೀನ್ ಹೋಸ್ಟ್ ಮಾಡ್ಬಿಡ್ತೀನಿ ಬಿಡು ನಾನು. ಓಕೆ
ಮೋಹನ್ ಯಾರೋ ಚೆನ್ನಪ್ಪನವರು ಯಾರೋ ಬರ್ತಿರ್ತಾರೆ.
ಬರ್ಲಿ ಯಾರೋ ಡೆಲಿಗೇಟ್ ಇರ್ಬೇಕು.
ಮೋಹನ್ ಸಿಯ
218 ಆಯ್ತಲ್ವಾ? ಸೊ ಈಗ ಎಲ್ಲಾರು ಓಪನ್ ಹೌಸ್ ಈಗ. ಅಗ್ಲಿ ಸರ್ ಜಾಯಿನ್ ಆಗ್ತಾ ಇದಾರೆ.
ನಿಮ್ದು ವಾಯ್ಸ್ ಒಂಥರ ಇದೆಯಲ್ಲ.
ಯಾಕೆ ಸರ್?
ಈಗ ಒಂಥರ ಲರಿಂಜೈಟಿಸ್ ತರ ಇದೆ.
ಕೊರೋನಾ ಬಂದವ್ರು ಹಂಗಿದ್ಯಾ? ಯಾರಿಗ್ ಗೊತ್ತು, ನಾನೊಂಥರ ಟೈಫಾಯ್ಡ್ ಮೇರಿ ತರ ಕರೋನಾ ಶರ್ಮ ತರ ಓಡಾಡ್ತಿದೀನಿ, ಏನೋ ಗೊತ್ತಿಲ್ಲ. ಅವ್ರು ಎಷ್ಟು ಗಂಟೆಗೆ ಜಾಯಿನ್ ಆಗ್ತಾರೆ ಸರ್ ಇವರು?
ಅವಾಗ ಹೇಳ್ತೀನಿ ನಾನು.
ಅಲ್ಲ ಇವ್ರು ಯಾವಾಗಲ್ಲ ಅವರು ದಿಲೀಪ್ ಯಾವಾಗಲ್?
ನಾ ಹೇಳ್ತೀನಿ ಅವ್ರಿಗೆ ಜಾಯಿನ್ ಏನು 1 hours ಟೈಮ್ ಅಂತ.
ಆಯ್ತು. ಅಲ್ಲ ಅವ್ರ ಏನಂತ ಇನ್ ಕೇಸ್ ಅವರು ಇವರೆಲ್ಲ ಎಳದ್ಬಿಟ್ಟು ಲೇಟ್ ಆದ್ರೆ ಅವ್ರದೇ ಫಸ್ಟ್ ಮಾಡ್ಬಿಟ್ಟು ನಿಮ್ದು ಆಮೇಲೆ ತಗೊಳ್ಳೋಣ ಅಷ್ಟೇ ಅಲ್ವಾ? ಸರಿ. ಎಲ್ಲ ಹಾಸ್ಪಿಟಲ್ ಇದ್ದೀರಾ ಮನೇಲಿ ಇದ್ದೀರಾ ಸರ್?
ಹಾಸ್ಪಿಟಲ್ ರೀ.
ಅಗಡಿ ಸರ್ ಜಾಯಿನ್ ಆದ್ರಾ?
ಆಗಿದ್ದಾರೆ
ಸರ್. ನಮಸ್ಕಾರ ಅಗಡಿ ಸರ್.
ನಮಸ್ಕಾರ ರೀ.
ಹಲೋ ಸರ್.
ನಮಸ್ಕಾರ. ವಂಡರ್ಫುಲ್.
ವಿಕ್ರಮ್ ಅವ್ರ ತಲೆಯಿಂದ ನೋಡಿ ಸರ್ ಫುಲ್ಲು ಕೆಥೆಟರ್ಗಳೇ ಓಡಾಡ್ತಾ ಇದಾವೆ.
ಇಲ್ಲ, ಅವ್ರ ಅಮಿತಾಬ್ ಬಚ್ಚನ್ ತರ ಇಂಪ್ರೆಸ್ ಮಾಡ್ತಾ ಇದಾರೆ ಅವರು.
ಅದೇ ಈಗ ಯೂಟ್ಯೂಬ್ ಲೈವ್ ಇದೆ, ಇದು ಯೂಟ್ಯೂಬ್ ಲೈವ್ ಶುರುವಾಗಿದೆ. ಸೊ ಎಲ್ಲರಿಗೂ ಕೊಟ್ಟಿದೀವಿ, ಇದು ಲಿಂಕ್ ಎಲ್ಲ ಕಳ್ಸಿದೀವಿ ಯೂಟ್ಯೂಬ್ ಇದಕ್ಕೆ. ಮೀಡಿಯಾದವರು ಒಂದು 3-4 ಜನಕ್ಕೆ ಕಳ್ಸಿದೀನಿ ಸೊ ಜಾಯಿನ್ ಆಗ್ಲಿಕ್ಕೆ. ಆ ಪ್ರೆಸ್ ರಿಲೀಸ್ ಒಂದು ಕಳ್ಸಿದೀವಿ ಎಲ್ಲಾರ್ಗು. ಹಾಯ್ ಅಮಿತ್.
ಹಾಯ್ ಶರ್ಮಾ.
ನಮಸ್ಕಾರ ರೀ ಅಮಿತ್.
ನಮಸ್ಕಾರ ಸರ್.
ಗುಡ್
ಆಫ್ಟರ್ನೂನ್ ಸರ್.
ನಮಸ್ಕಾರ.
ಇದು ಲಿಂಕ್ ಇದೆ ತಾನೆ? ಮತ್ತೆ ಬೇರೆ ಯಾವ್ದು ಲಿಂಕ್ ಇದೆಯಾ?
ಹೌದು, ಅದೇ ಝೂಮ್ ಲಿಂಕೆ. ಈಗೇನ್ ಗೊತ್ತಾ, ಈಗ ಮೀಟಿಂಗ್ ಓಪನ್ ಇರೋದ್ರಿಂದ ಎಲ್ಲ ಡೈರೆಕ್ಟ್ ಆಗಿ ಅವ್ರದ್ದು ಇಮೇಲ್ ಐಡಿ ಮತ್ತೆ ಹೆಸರು ಹಾಕಿದ್ರೆ ಡೈರೆಕ್ಟ್ ಲಾಗಿನ್. ಈಗೇನು ಇದೇನಿಲ್ಲ, ರಿಜಿಸ್ಟ್ರೇಷನ್ ಏನಿಲ್ಲ ಈಗ.
ಸರಿ.
ಅದು ಅವಾಗಾದ್ರೆ ಮುಂಚೆ ಆದ್ರೆ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಕಳಿಸಿ ಇಮೇಲ್ ಕಳಿಸ್ತಾ ಇದ್ರು. ಈಗ ಜಸ್ಟ್ ಆ ಝೂಮ್ ಲಿಂಕ್ ಕ್ಲಿಕ್ ಮಾಡಿದ್ರೆ ಅಲ್ಲಿಗೆ ಲಾಗಿನ್ ಆಗುತ್ತೆ.
ಶರ್ಮಾ, sometimes there could be background noise from the audience. ಅದನ್ನ ಸೆಂಟ್ರಲ್ ಮ್ಯೂಟ್ ಮಾಡಬಹುದಲ್ಲ ಅವ್ರನ್ನ?
ಇವ್ರು ಅನಿಲ್ ಮಾಡ್ತಾ ಇದಾರೆ ಸರ್. ನಮ್ಮ
ಹುಷಾರಾಗಿ ಮಾಡ್ಬೇಕು, ಯಾಕಂದ್ರೆ ಎಲ್ಲರಿಗೂ ಸೇರ್ಕೊಂಡ್ಮೇಲೆ it could be a chaotic.
ಇಲ್ಲ, we will mute everybody except the speaker. We will mute everybody.
Yes
sir. ಏನ್ ಬರೀ ಮ್ಯೂಕರ್ಗಳೇ ಆಗಿದಾವೆ ಸರ್ ಆಸ್ಪತ್ರೆ ತುಂಬಾ.
ಕರೆಕ್ಟ್.
ಇವತ್ತು 2 ಕೇಸ್ ಆಪರೇಟ್ ಆಯ್ತು ನಮ್ದು. ಒಬ್ಬ ಡಾಕ್ಟರ್ ಫಾದರ್ ಏನ್ ಮೆಡಿಸಿನ್ ಸಿಗ್ತಾ ಇಲ್ಲ, ಬಹಳ
ಬಟ್ ನಂಬರ್ ಸ್ವಲ್ಪ ಕಡಿಮೆ ಆಗಿದೆ ನಮ್ಮಲ್ಲಿ. ಇವತ್ತು ಬೆಡ್ ಇದೆ ಅಂತ ಹೇಳಿದ್ರು.
ಬೆಡ್ ಸಿಗ್ತಾ ಇದೆ, ನಮ್ಮಲ್ಲೂ ಬೆಡ್ ಸಿಗ್ತಾ ಇದೆ. ಕರೆಕ್ಟ್.
ನಮ್ಮಲ್ಲೂ ಅದೇ ಕತೆ.
ನಾನ್ ಐಸಿಯು ಬೆಡ್
ಅಲ್ಲ, ನಾನ್ ಐಸಿಯು ಓಕೆ ಸರ್. ಈಗ ನಾವ್ ಇದ್ದೀವಲ್ಲ ವಾರ್ಡ್ ಅಲ್ಲೇನೆ ಆಕ್ಸಿಜನ್, ರೆಮ್ಡೆಸಿವಿರ್, ಸ್ಟಿರಾಯ್ಡ್ ಕೊಟ್ರೆ ಇಂಪ್ರೂವ್ ಆಗೋರು ಯೂಶಲಿ ಇಂಪ್ರೂವ್ ಆಗ್ತಾರೆ. ಒನ್ಸ್ ದೇ ಗೋ
ಐಸಿಯು ಬೇಕು ಅಂತ ಬೆಡ್ ಹುಡುಕ್ತಾರಲ್ಲ, ಅವ್ರಿಗೆ ಸಿಗ್ತಾ ಇಲ್ಲ.
ಅವ್ರಿಗೆ ಸಿಗ್ತಾ ಇಲ್ಲ. ಕರೆಕ್ಟ್.
ಕರ್ನಾಟಕ ಸ್ಪೋರ್ಟ್ಸ್ ಫೌಂಡೇಶನ್ ಯಾರ್ರಿ ಇದು?
ನಮ್ದು ಇದು ಅಡ್ಮಿನ್ ಸರ್. ಅದು
ಅಡ್ಮಿನ್ ಅಲ್ಲ?
ಎಲ್ಲಾನು ಇದ್ ಮಾಡ್ಬೇಕಲ್ಲ, ತಗೋಬೇಕು. ಯೂಟ್ಯೂಬ್ ಲೈವ್ ಇದೀವಿ. ಅದು ಲಿಂಕ್ ಚೇಂಜ್ ಆಗಿದೆ, ಯೂಟ್ಯೂಬ್ ಲಿಂಕ್. ಅದು ಹಳೆ ಲಿಂಕ್ ವರ್ಕ್ ಆಗ್ಲಿಲ್ಲ, ಅದಕ್ಕೆ ಈಗ ಹೊಸ ಲಿಂಕ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿದೀವಿ. ದಯವಿಟ್ಟು ಹೊಸ ಲಿಂಕ್.
ನಾವು ಮಾತಾಡೋದೆಲ್ಲ ರೆಕಾರ್ಡ್ ಆಗ್ತಾ ಇದೆಯಾ?
ಹೌದು, ಅದನ್ನೇ ನಾನು ಹೇಳಿದ್ ಯೂಟ್ಯೂಬ್ ಲೈವ್ ಇದೆ ಅಂತ.
ವಿಕ್ರಮ್, ಡಾಕ್ಟರ್ ದಲೀಪ್ ಅವರಿಗೆ ಬೆಳಿಗ್ಗೆ 6 ಗಂಟೆನಾ ಈಗ
ಅಲ್ಲಿ 10:30 ಅಂತ ತೋರಿಸ್ತಾ ಇದೆ ಸರ್.
ನಮಗೂ ಅವ್ರಿಗೂ 9:30 ಗಂಟೆ ವ್ಯತ್ಯಾಸ
ಅಲ್ಲ.
ನಾನು ನೋಡ್ತೀನಿ ಸರ್, ಮೆಸೇಜ್ ಕಳಿಸ್ತೇನೆ ನಾನು.
ಅಲ್ಲ, ನ್ಯೂಯಾರ್ಕ್ ಅವರು.
ಮಿಯಾಮಿ
ಅಂದ್ರೆ 9:30 ಗಂಟೆ ಆಲ್ಮೋಸ್ಟ್
ಬೆಳಗ್ಗೆ.
ಅವ್ರು ಬೆಳಿಗ್ಗೆ ನಮ್ಗಿನ ಹಿಂದೆ ಇರ್ತಾರಲ್ಲ ಅವರು.
ಅಲ್ಲ, ಬಟ್ ಆ ಕಡೆ
4:53 AM, 5 AM.
ಅದಕ್ಕೋಸ್ಕರ ಅವ್ರದ್ದು ಟೈಮ್ ಬರೋ ಅಷ್ಟೊತ್ತಿಗೆ ಬೆಳಿಗ್ಗೆ 6:30 7 ಗಂಟೆ ಆಗಿರುತ್ತೆ. ಅಂದ್ರೆ ಇಫ್ ಈಸ್ ಟು ಲಾಗ್ ಇನ್ ವಿತ್ ಅಸ್ ಎಟ್ ಅರೌಂಡ್ 3:30, ಅವಾಗ ಅವ್ರಿಗೆ ಬೆಳಗಿನ ಜಾವ. ಈಸ್ ಅವೇರ್ ಆಫ್ ದಟ್?
He only suggested that time, sir. Actually, I suggested little bit later.
ಐ ಥಿಂಕ್ ಇವತ್ತು ಬೇರೆ ಕಡೆಯಿಂದೆಲ್ಲ ಇದು ನಡೀತಾ ಇದೆ.
Today they are launching this World Thrombectomy Day, sir.
ಅಲ್ಲಲ್ಲ, ಅದಾಯ್ತು. ಐ ಥಿಂಕ್ ಈಸ್ಟರ್ನ್ ಕಂಟ್ರೀಸ್ ಅಲ್ಲೆಲ್ಲ ಸುಮಾರು ಕಡೆಯಿಂದೆಲ್ಲ ಅದು ಇದಾಗ್ತಾ ಇತ್ತು. ನಾನು ರಿಜಿಸ್ಟರ್ ಮಾಡೋಣ ಅಂತ ಹೋದ್ರೆ ಇಟ್ ಆಸ್ಕ್ ಫಾರ್ ಡಾಲರ್ಸ್. ಐ ಸೆಡ್ ಐ ಜಸ್ಟ್ ಸಿಂಪ್ಲಿ ಕೇಮ್ ಔಟ್ ಆಫ್ ದಟ್.
Correct. Adರಲ್ಲಿ I am presenting, sir.
Oh, wonderful.
Hello, Dr. Savit.
Hi,
Good afternoon.
Good afternoon.
ಸಂಕೀರ್ಣ ದೀರ್ಘ ಹೋಗಿದೆ ನೋಡಿ ಅಲ್ಲಿ.
ಸಂಕೀರ್ಣ ಸರ್, ಸಂಕೀರ್ಣ ಅಲ್ಲ.
ಸಂಕೀರ್ಣ ಅಲ್ವಾ?
ವಿಚಾರ ಸಂಕೀರ್ಣ ಅಷ್ಟೇ.
ಸಂಕೀರ್ಣ ಅಲ್ಲ.
ಸೆಮಿನಾರ್ ಇಲ್ಲ ಸೆಮಿನಾರ್. ಸಂಕೀರ್ಣ ಆದ್ರೆ ಕಾಂಪ್ಲೆಕ್ಸ್ ಆಗುತ್ತೆ.
ಓ, ಐ ಸಿ. ಸಂಕೀರ್ಣ ಮೀನಿಂಗು?
ಸಂಕೀರ್ಣ ಸಿಂಪೋಸಿಯಂ ಅಂತ. ವಿಚಾರ ಸಂಕೀರ್ಣ ಮೀನ್ಸ್ ಸಿಂಪೋಸಿಯಂ ಅಥವಾ ಸೆಮಿನಾರ್ ಅಂತ ಬರುತ್ತೆ.
ದೀರ್ಘ ಕೊಟ್ರೆ ಅಲ್ಲಿ
ಸಂಕೀರ್ಣ ಅಂತಂದ್ರೆ ಸಬ್ಜೆಕ್ಟ್ ಕಾಂಪ್ಲೆಕ್ಸ್ ಅಂತ ಬರುತ್ತೆ. ಸಂಕೀರ್ಣವಾಗಿದೆ ಅಂತ, ವಿಷಯ ಇಸ್ ವೆರಿ ಕಾಂಪ್ಲಿಕೇಟೆಡ್ ಅಂತ. ಸೊ ವಿಕ್ರಮ್ ಅವ್ರು ಕಾಂಪ್ಲಿಕೇಟೆಡ್ ಆಗಿ ಮಾತಾಡ್ತಾ ಇದ್ದಾರೆ, ಹಾಗಾಗಿ ಸಂಕೀರ್ಣನೂ ಗ್ರಾಮ್ಯಾಟಿಕಲಿ ಕರೆಕ್ಟ್.
ನೋಡಿ, ಈಗ ಟ್ರೂ ಟು ಥ್ರಾಂಬೆಕ್ಟಮಿ ಡೇ ವಿಕ್ರಮ್ ಸರ್ ಒಬ್ರೆ ಕರೆಕ್ಟ್ ಆಗಿ ಇದ್ರಲ್ಲಿ ಇದಾರೆ, ಥ್ರಾಂಬೆಕ್ಟಮಿ ಡ್ರೆಸ್ ಅಲ್ಲಿ ಇದಾರೆ.
ಬಿಡ್ರಿ, ಮನೆ ಆಗ್ಲಿಲ್ಲ.
ಕರೆಕ್ಟ್.
ಇಲ್ಲ, ಇದು ನಮ್ ಡೈಲಿ ಯೂನಿಫಾರ್ಮ್ ಆಗಿದೆ. ಮನೆಯಿಂದ ಬಂದ ಹಾಸ್ಪಿಟಲ್ ಬಂದ ತಕ್ಷಣ ಇದನ್ನ ಚೇಂಜ್ ಮಾಡ್ತೀವಿ ನಾವು. ಸೊ
ನಾವು ಬರೀ ಕೋವಿಡ್ ರೌಂಡ್ಸ್ ಇದ್ರೆ ಅಷ್ಟೇ ಹಾಸ್ಪಿಟಲ್ ಸ್ಕ್ರಬ್ಸ್, ಇಲ್ಲ ಅಂತಂದ್ರೆ ಏನಿಲ್ಲ.
ಹೌದ್ರಾ?
ಕರೆಕ್ಟ್.
ನಮ್ದು OPD ಅಲ್ಲೂ ಇದೇ ಆಗ್ಬಿಟ್ಟಿದೆ ಈಗ 1 ವರ್ಷದಿಂದ.
ನಂದೇ ಕೋವಿಡ್ ರೌಂಡ್ಸ್ ಇತ್ತು, ಮುಗಿಸಿ ಬಂದೆ. ಮತ್ತೆ ಎಲ್ಲ ಡ್ರೆಸ್ ಎಲ್ಲ ಇದ್ ಮಾಡ್ಬಿಟ್ಟು ಬಂದೆ.
What is this background bell noise?
When people join, it will.
No, I see.
ಎಲ್ಲ ಜಾಯಿನ್ ಆದಾಗ ಇದು ಬರುತ್ತೆ ಸರ್. ಚಿನ್ಮಯ್ ನಾಗೇಶ್ ಇಸ್ ಜಾಯಿನಿಂಗ್. ವಿ ಆರ್ ಅಡ್ಮಿಟಿಂಗ್ 1 by 1 ಆಕ್ಚುಲಿ. ನಾನು ಮತ್ತೆ ಅಡ್ಮಿನ್ ಎರಡುವೆ ವಿ ಆರ್ ಅಡ್ಮಿಟಿಂಗ್ 1 by 1 ಸೊ ದಟ್ ಅದ್ ಸೌಂಡ್ ಬರುತ್ತೆ ಟನ್ ಅಂತ. ಟ್ವೆಲ್ವ್ ಮೆಂಬರ್ಸ್ ಇದಾರೆ. ಸುಭಾಷ್ ಸರ್ ಇನ್ನೂ ಜಾಯಿನ್ ಆಗಿಲ್ಲ. ಸುಭಾಷ್ ಸರ್ ಒಂದು ಫೋನ್ ಮಾಡುವ ಸರ್, ಇನ್ನು ಟೈಮ್ ಇದೆ, ಇನ್ನು 4 minutes ಇದೆ.
Good afternoon, Agri sir.
ನಮಸ್ಕಾರ.
ಸವಿತ್ ಸರ್ ನಮಸ್ಕಾರ.
Good afternoon, Sharma sir. Good afternoon, Vikram sir. Hello, Amit sir.
Hi, Dr. Savit.
2 minutes to go.
Yes, sir. Subhash sir ಒಂದು ಫೋನ್ ಮಾಡಲ ಸರ್? ಫೋನ್ ಮಾಡ್ತೀನಿ. ಹಲೋ. Good afternoon, Mahendra sir.
Good afternoon, sir.
Hello.
Good afternoon, sir.
Hi. Good afternoon, sir. Good afternoon. Thank
Welcome,
you so
sir.
much for permitting me to attend.
Welcome, sir. In 2 minutes, we'll start, sir. 1 or 2 minutes.
एक मिनट
Can we start? Good afternoon.
Yeah, please.
Yeah. Everyone, namaskara. Good afternoon, respected senior colleagues and friends. Today is a very important and auspicious day for all of us, especially those who are working in the area of stroke neurology. For the first time, the Society of Vascular and Interventional Neurology has announced a day to dedicate, for mechanical thrombectomy, to create awareness for the public, for the policymakers, for stroke survivors, and to create education and training for the junior neurologists and interventional neuroradiologists. So we have, there are 2 days of program going on everywhere. As a part of that, Karnataka Stroke Foundation is happy to host you all to this scientific symposium on mechanical thrombectomy. So Karnataka Stroke Foundation is a not-for-profit charitable trust founded by some of the eminent neurologists of the city. And we, on behalf of the Karnataka Stroke Foundation, I welcome you all to the virtual webinar on the occasion of World Stroke Mechanical Thrombectomy Day 2021. 15 years back, when World Stroke Day was started as an awareness campaign, the stroke awareness among the public, among the policymakers, among the hospitals, among other colleagues, like especially I would say even the emergency physicians or ICU doctors was very poor. But over time, I would say that World Stroke Day or Stroke Awareness Campaign is one of the most successful health awareness campaigns in the 21st century. In the similar lines, I think this is the first World Stroke Mechanical Thrombectomy Day which we are observing, and I'm sure in the coming days this is going to cover larger audience and larger population. I'm sure the whole country is, in a testing time of COVID pandemic, which has affected every, literally everyone, every city. So in this context, I welcome everybody. Subhash sir is there? Dr. G.D. Subhash? Admin Subhash sir has joined?
No, doctor.
Okay, so without, I think there is some technical delay. On behalf of the president of Karnataka Stroke Foundation, Dr. G.T. Subhash, I welcome all the panelists, Dr. Amit Kulkarni, Dr. Savit Kumar, Dr. Raghunandan Nadik, Dr. Vikram Huded, and the guest speaker of today's day, Dr. Dilip Yavgal, who is the global chair for Mission Mechanical Thrombectomy Initiative. And on behalf of the entire MT 2020 plus committee, he is going to deliver the keynote address. So I also, welcome all the senior neurologists. Professor Mahendra had joined from Delhi, and Dr. Suresh Rajendra Dugani and many other friends have joined. So let's, without wasting any more time, I invite the first speaker for today's seminar, Dr. Amit Kulkarni. Dr. Amit Kulkarni is a senior consultant neurologist, and he's the lead for neurology services at Sparsh Hospitals, Rajarajeshwari Nagar, Bangalore, and also Infantry Road. May I request Dr. Amit Kulkarni to start his presentation, please.
Thank you, Dr. Sharma, and thank you for all the office bearers of Karnataka Stroke Foundation, all my senior colleagues and my teachers who are already on the forum. I would like to start sharing my slides. Just allow me a couple of minutes, please. Okay, I hope my slides are visible.
Yes, doctor, you can go ahead.
So I think Dr. Sharma very nicely introduced the whole concept to the audience today, and World Stroke Thrombectomy Day is in itself a big success for all the interventions and for all the things that have happened post 2015, and for all the good things that's going to happen in the future as well. So without wasting much time, I would like to come to my talk, but then it's quite abrupt if I can just go to that particular topic as per se. So the different types of strokes we all know, about 15 to 40% in different studies are large artery atherosclerosis. Small vessel occlusions or lacunae constitute about 15 to 30%. Cardioembolic strokes anywhere between 15 to 30%, sometimes more according to few studies. Cryptogenic strokes anywhere up to 40%, and there are other causes as well. Now, we know all the stroke risk factors. We have modifiable as well as non-modifiable risk factors. I would just go through it quickly. Hypertension, diabetes, atrial fibrillation, dyslipidemia, smoking, tobacco, sedentary lifestyles, kidney disease, sleep apnea, heavy alcohol intake, and diet. So these are all the modifiable risk factors, while non-modifiable risk factors are male sex, genetic susceptibility, and age. Why are we here today, and why these talks are being held? So this is because of the LVO burden that we have today. So LVO is large vessel occlusions. The estimated incidence of anterior circulation large vessel occlusion was 12.5 per lakh persons per year. LVO stroke patients were more commonly female than male, 67% versus 31%. LVO stroke patients were older than non-large vessel occlusion strokes. So generally, older the patients, they presented more frequently with LVO than the younger patients. LVO patients had a higher 30-day mortality of 31% versus 4.6% when it was a non-LVO. And they had a median or a longer hospital stay as compared to the non-LVOs. So this diagram is telling us that post-vascularization, there was a significant reduction in both mortality as well as disability at 90 days, with an NNT which is remarkable of 2.6. And without thrombectomy, when there was no revascularization, 64% of the patients were either dead or dependent at 3 to 6 months. Hence, the important need and the need for the public awareness in general. So LVO mechanisms, these are the standard mechanisms of stroke. So primary occlusion at the arterial site, that is by atherosclerosis. Secondly, it could be because of plaque rupture or embolism that goes into the intracranial vessel, causing an intracranial occlusion. Thirdly, cardioembolic strokes. The principal reason among them is atrial fibrillation. And finally, cryptogenic strokes. So all these are the usual mechanisms which also contribute in LVO. It's important to understand the cerebral autoregulation. So cerebral blood flow is something that is maintained despite variations in perfusion pressure. So the smooth muscles contract when cerebral perfusion pressure increases and relax when it drops. So nitric oxide plays a very important role in this autoregulation. So what we see is between the pressure ranges between 50 to 150 millimeters of mercury, the brain has got a remarkable capacity to autoregulate. But once it goes beyond this, the CBF either increases or decreases with CPP, and at this juncture, it becomes extremely dangerous. So this is the autoregulatory, the zone, what we call it, between 50 to 150. So when we have blood pressure, cerebral perfusion pressure, which is going beyond this particular area, generally when there is a chronic hypertensive, this curve shifts towards the right, while hypercapnic, this curve shifts upwards and towards the right. While in people who are hypocapnic, this curve shifts downwards. While when you see the patient is having an acute ischemic stroke, whether be it ischemic core or be it the ischemic penumbra, what we see is that this particular autoregulation is lost. And this is what leads to dangerously high pressures, which leads to either cerebral edema or it can lead to an acute infarct. So after an acute stroke, cerebral autoregulation is known to be impaired, and with the increasing dependence of cerebral perfusion on the systemic pressures. So what is important here is that brief and drastic blood pressure drops in the first 24 hours of an acute ischemic stroke has been shown to contribute to the loss of penumbra. So penumbra, as we said again, it is something which the artificially elevated blood pressures tends to maintain it. But when it's drastically lowered by drastic lowering of blood pressure, this leads to the loss of penumbral tissue. And that is what worsens the ischemic stroke. So in general, when we look at the cerebral blood flow, which is normally between 50 to 55 mils per 100 grams per minute, when it comes to 35 to 25 mils, it is called oligemia, where there is a little bit of biochemical changes in the form of protein synthesis, or glycolysis is increased, anaerobic. While 18 to 25, when it drops to further to 18 to 25, it leads to ischemia, and this leads to a little bit of synaptic potential changes. It leads to further anaerobic glycolysis, and it leads to lactic acidosis. But when it comes to less than 10, this leads to an acute infarct. So what is generally seen by the radiologists or the neurologists? So what happens here is in the penumbra, what we're looking at is what we call a CBV-CBF mismatch, or what we call as the MTT versus CBV mismatch. So what happens here is there is an increased MTT or Tmax. There's a moderately reduced CBF. Please remember, it's moderately reduced. And the CBV is either near normal or it is increased. This is very, very important. So there's a mismatch between the MTT, the CBF, and the CBV. But what happens when the ischemia persists for a longer time, or when there are no collaterals recruited, or when there is no revascularization that happens in time? It leads to a formation or an increase of core tissue, and that core tissue is marked by markedly decreased CBF. So please remember, it's markedly decreased CBF, and here what happens is the CBV also starts to reduce. So this is very, very important. So when it is not revascularized in time, what you find is the CBV also starts reducing, and that leads to expansion of the infarct core. So this is again the same thing, the tissue where this is the penumbra and this is the oligemia, and this is a function of time. If within that particular time, if there is no revascularization, no recruitment of collaterals, adequate recruitment of collaterals, the oligemia goes into the penumbra, and the penumbra can become an infarct zone. So what we see on diffusion, I think these are this is a thing which will be covered by my subsequent speaker. We must remember is when the CBF is less than 10, it leads to neuronal paralysis and reversible ischemia. And this is what happens. There is a lot of inflammatory infiltrates. There is viable neurons when it is a penumbra, while when it's an ischemic core, what happens is the neuronal swelling starts, cytoplasmic swelling starts, there's vacuolation, and there's a further necrosis. So this is the overall flowchart which tells us that there's a membrane depolarization, the cytotoxic edema, there is an activation of procoagulant pathway, and there is cell injury and cell death, finally leading to liquefactive necrosis. So this is all the pathophysiology of what happens. So what are the large vessels of the brain? So MCA has M1 and M2, ACA, A1, some people include A2 as well. ICA is basilar artery, and PCA, even sometimes P2 PCA is included in that. So when we look at LVO stats, LVO accounts for 24 to 38% of acute ischemic strokes. And when we include both A2 segment as well as the P2 segment, we find that 24 to 46% of acute ischemic patients are included. So 70 to 80% of LVOs occur in the anterior circulation. The rate of atrial fibrillation among LVOs is much higher than non-LVOs. So again, leading us to tell us that atrial fibrillation leads to more larger clots, leading to occlusion of larger arteries. And here the p-value is significant. And 15% of patients presenting with TIAs tend to have LVOs. So why LVOs are important? Again, this is another slide which tells us when we look at the NIHSS, when it goes from 0 to 9 to a moderate range to 20 to 42, which is severe NIHSS, we find that the mortality keeps increasing. So the LVO are the patients where the mortality goes very high, or the dependence goes very high. While when you look at a non-LVO, we don't see that proportionate increase in the mortality or the dependency. So what are these different scales which help us in understanding whether it's an LVO or not? Of course, these are not foolproof, but these can help us sometimes even in a pre-hospital setting to diagnose whether this is an LVO or not an LVO. So facial droop, extremity paralysis, speech, vision, and gaze. So all these are graded and they have given points. Gaze is given a point of 4. So 1 to 4 predicts that it's probably not an LVO, and more than 5 predicts it's an LVO with a highest score of 0 to 8. So what are these factors clinically when we look at? Of course, the radiological parts will be spoken by our subsequent speakers, but when it comes to the clinical aspects, it's very important to understand that the visual disturbances, aphasia, and neglect, when you look at these 3 parameters, we know that this is likely to be an LVO. So VAN scoring it is comparative in sensitivity of 79% and negative predictive value to NIHSS greater than or equal to 6. So along with NIHSS, this is something, NIHSS is a little more complicated, a little more tough in the routine settings for people to score it. But when we look at this kind of scoring, which is very simplified, we understand that this is something which can further evolve and help us in quick identification of LVOs. Other than that, we have something called as race scale. Here again, we have all the different parameters of facial palsy, arm, leg motor, gaze deviation, aphasia, and agnosia. And again, here we have a total point scoring of 0 to 9. And if race score is more than 5, it's something that indicates that this is most likely to be LVO with a sensitivity of around 85%, specificity about 68%. So now NIHSS alone, when we look at it, what was the cutoff? We found that more than 7 NIHSS score had a positive predictive value of 84% for LVO. So, it's very important that you grade the NIHSS in the emergency itself, where it straight away gives you an idea, even before you do an imaging, that this is likely to be an LVO, and that's where you can alert your interventionist. Hello, sorry.
Yeah, please go ahead, Dr. Amit.
Okay, so there are symptoms. What are the symptoms of LVO? I think apart from the routine symptoms of hemiparesis, hemiplegia, hemisensory disturbances, facial droop, and dysarthria, as compared to small vessel occlusions, LVOs, we have already spoken about, additionally have cortical signs, gaze deviations, visual field defects, visual and sensory extinction, aphasia, and agnosia. So cortical signs tends to help us with just quick diagnosis of LVO. These symptoms indicate hypoperfusion of the cerebral cortex. So this already I have spoken about. While when we compare to non-LVO, generally they present with these typical lacunar syndromes, which we are all aware of. So these are pure motor strokes. They typically happen with posterior limb of internal capsule, corona radiata, or basis pontis. It can be pure sensory strokes, which happen with thalamic strokes. Sensory motor strokes, where thalamus or adjacent internal capsule can be involved. Dysarthria, clumsy hand, as we all know, is between the rostral 1/3 and the caudal 2/3 at the base of the pons. Ataxic hemiparesis, where it can occur in the posterior limb of the internal capsule or the base of the pons, or you can have movement disorders like hemibalismus, which is in the subthalamic nucleus. So all of these are probably lacunar syndromes, so they are unlikely to be, although we cannot be 100% certain, but with a reasonable accuracy, when we have cortical signs, we conclude that they are possibly LVOs. So what are the different syndromes? When it comes to large vessel syndromes, internal carotid artery, combined ACA and MCA involvement is there. They can have ipsilateral monoocular loss, which is amaurosis. Left ACA involvement can cause a right-sided leg numbness, weakness, transcortical aphasias, idiomotor apraxias. Right ACA can cause a reverse left numbness and weakness, motor neglect, idiomotor apraxia. Left MCA, as we all know, can cause a differential weakness, arm more than leg, aphasia, gaze preference. Right MCA can cause again a left-sided, along with hemispatial neglect, gaze preference, astereognosia. So again, everything boils down to cortical signs. Basilar artery occlusions can present with different syndromes. Again, top of basilar can cause somnolence, convergence, nystagmus, Q deviation, vertical gaze paralysis. Mid basilar can cause loss of facial sensations, ipsilateral ataxias. Proximal basilar can cause quadriplegia, horizontal gaze paralysis, bifacial weakness, and preservation of vertical eye movements. PCA syndromes again can cause homonymous hemianopia in various combinations. They can cause alexia without agraphia. They can cause cortical blindness when it's bilateral. So when it comes to posterior circulation, there are a few things which can help us in identifying quick identification, whether it's a vestibular syndrome versus a posterior circulation stroke. Here it is diplopia, dysarthria, dysphagia, dysphonia when they're present along with giddiness. It can help us in diagnosing. Vertical or direction changing nystagmus can help us in diagnosing. Skew deviations when present can help us in understanding that this is probably a posterior circulation stroke. Normal head impulse test. Again, head impulse test when it's abnormal suggests an acute vestibular syndrome. Presence of focal signs, presence of sudden onset pain, which could mean dissections, and presence of risk factors. So again, this is not very typical of an LVO, but then this definitely helps us in the emergency when we localize between a vestibular syndrome versus a posterior circulation stroke. So with this, I think I would like to end my talk and with my take-home message. NIHSS of more than 7 is suggestive of LVO, more so when associated with the cortical signs, when associated with vision, when associated with aphasia, and when associated with neglect. Presence of cortical signs when present are suggestive of LVO. Pre-hospital scales can help in quick identification of large vessel occlusions. CTP, CT perfusion, MR-based perfusion studies with mismatch can help in identifying penumbra. CBF less than 10 indicates an infarct core, while something between 11 to 20 indicates penumbra. And rapid revascularization can help in improving mortality as well as in minimizing long-term disability, as the subsequent speakers will tell you with various cases and other studies. With this, I would like to thank one and all, and I would like to end with this slide. This is not a very pleasant looking slide, but I hope that 2 years or 3 years down the line, at least we can get back to this kind of crowds again in the future. Thank you, one and all.
Yeah, thank you, Dr. Amit. It was a wonderful lecture on the pathophysiology and symptomatology of stroke. We will take up the question and answer in the end. I request all the delegates to post your question in the chat box so that we'll take it up, and during the end, we'll have a panel discussion. Let's move on to the second talk. This is about the neuroimaging. Neuroimaging, as you all know, is one of the most important, single most important investigation deciding the treatment treatment strategies in acute ischemic stroke. to highlight the importance and to discuss about the imaging modalities, we have Dr. Savit Kumar. Dr. Savit Kumar is a consultant in interventional neuroradiology at Apollo Hospitals, Banerghatta Road. He is an astute academician with more than 25 publications. So he has been part of our mechanical thrombectomy team here. So with this small introduction, I would like to invite Dr. Savit Kumar to present his lecture on neuroimaging in acute ischemic stroke.
Thank you, Sharma sir, and thank you all for giving me this opportunity to present. Can you see my slide?
Yeah, we can see. We can see.
So I will discuss about the neuroimaging in stroke, mainly highlighting the typical imaging features and how to identify them, and what is the utility of imaging in acute ischemic stroke. So the central goal of therapy in acute ischemic stroke is to preserve the tissue in the ischemic penumbra. So the role of imaging is to exclude an hemorrhage to begin with, to identify the infarct, quantify the degree of territorial loss, the various scoring systems which has been given, detection and localization of the large vessel occlusion, selection of the patient for treatment, endovascular or intravenous thrombolysis, and with the role of treatment in the extended window, timing of an infarct. Now, before we go into the imaging, the zones of ischemia are, one is the core, which is the irreversible part of the damage, and penumbra, which is a reversible part of the ischemic tissue. Now, this is what is targeted during the treatment, and the role of imaging is to pick up this penumbra. Now, the choice of imaging, whether it is MR based patient selection or evaluation, or CT based patient selection evaluation, is depend on the availability of each of these techniques and the speed of performing them and the patient cooperation. Now, coming to the imaging features of stroke in a non-contrast CT. So when it is a CT based evaluation or patient selection, the first what is performed is a non-contrast CT, which will give us an information about the infarct core. The infarct core on a non-contrast CT will appear as a loss of gray white matter differentiation. This is best assessed when seen with a narrow window. So this is best assessed when seen with a narrow window. The recommended width and level are 8 to 40 HU and 32 to 40 HU. Now this setting increases the chance of picking up these subtle changes. Now this is an illustration of a loss of gray white matter differentiation in the insula, called as the insular ribbon sign. This is an illustration of obscuration of the lentiform nucleus and caudate head. And when the changes are well established, what you see is a well-defined hypodensity with loss of gray white matter differentiation and sulcal effacement. This extent of infarct can also be quantified. There are many scoring systems. One is the most commonly used for the anterior circulation of the aspect scoring system, where there are 10 points given to 10 various locations of the basal ganglia and the middle cerebral artery territory. With a higher the scoring representing a smaller infarct, and lesser the scoring representing a larger infarct size. A similar scoring system exists for the posterior circulation, called as a posterior circulation aspects, where the scoring is done for the occipital lobe, the thalamus, the midbrain, and pons. Again, the score is out of 10. The vessel occlusion also can be identified on a non-contrast CT. Now, this is seen as an hyperattenuating vessel or a hyperdense MCA sign. Now, this is mainly when it is a RBC-rich clot, which appears as hyperdensity on a non-contrast scan. A similar hyperdensity which is seen in the Sylvian fissure region would suggest an MCA dot sign, suggesting an occlusion of the M2 division of the middle cerebral artery. A similar appearance, the basilar artery hyperdense sign, suggesting an occlusion of the basilar artery. And a non-contrast CT will also be helpful in picking up stroke mimics, mainly large mass lesions, which will predominantly have a vasogenic edema compared to a loss of gray white matter differentiation seen in an acute infarct or hyperacute infarct. The next next thing after we identify the infarctus to confirm the large vessel occlusion. So this is best performed by CT angiogram. Now CT angiogram is usually performed. The CT angiogram is usually performed with a bolus contrast injection through a large bore cannula, that is usually 18 to 20 gauge cannula in the preferably in the cubital vein, and it can be done in a single phase fashion or a multi-phase fashion. This CT angiogram will give us information on the large vessel occlusion. Now, this is an illustration which is showing a large vessel occlusion, the extent of the clot, that is the clot burden, and also will give us an idea on the collateral score. Now, the CT angiogram are best interpreted for a faster and accurate interpretation using the MIP images, especially for the intracranial circulation. Using a coronal MIP is very useful for picking up the occlusions in the internal carotid artery, supraclinoid segment of the internal carotid artery, the middle cerebral artery and anterior cerebral artery. And the sagittal images, sagittal MIP images are more useful in picking up the occlusion in the smaller vessels, that is the M2 branches, or in the A2 branches. And the coronal images again useful for picking up the occlusions in the basilar artery. Now the clot burden score is the extent of the scoring given for the extent of the clot involving the anterior circulation. Now it is a scored out of 10 with based on each area being involved minus out of the 10, and the lesser the score, they have a larger final infarct size and poorer outcome. Now, the collateral assessment can be done on a single phase CT or on a multi-phase CT. The multi-phase collateral score assessment is more superior to the single phase CT because one of the important things which will underestimate the collateral score is a tandem lesion or a critical stenosis in the neck vessel, which this can easily be overcome by using a multi-phase collateral scoring system. So here, 3 phases of images are required. The first phase from the aortic arch to the vertex, the second 2 phases, which includes only the from the skull base to the vertex. The first phase covers the early arterial phase, the second is a late arterial, and third is a venous phase. So based on the rapidity of appearance of the arteries and the density of the contrast and the caliber of the arteries, they are graded into good collaterals, intermediate collaterals, and poor collaterals. The other advantage of a multi-phase CT is it is helpful in picking up small distal M2 lesions with a sign called as a delayed vessel sign. Here we see an M2 occlusion with delayed appearance of the M2 branch. Now, this increases the ability or the chance of picking up a distal M2 occlusion. Now, there are various collateral systems based on the single phase CT angiogram. Now, these collateral systems are usually based determined by comparing the number of vessels to the contralateral normal hemisphere. Now, various has been described: the TAN, the modified TAN, and the MAS system. The most easy and the simpler one to follow will be the modified TAN system, which just divides the collaterals into good or bad collaterals. Good collaterals where you have the vessels more than 50% as compared to the opposite side, and if the number of vessels is less than 50% as compared to the opposite side, it is called as bad collaterals. Now, the next imaging modality, that is CT perfusion, very much useful when evaluating a stroke in an extended window. Now, this is again performed with a bolus contrast injection. The amount of brain coverage is determined by the number of detectors in a scanner. The higher detector scanner can have a wider brain coverage compared to the lower detector scanner. So images are acquired repeatedly at a particular region of interest after a bolus contrast injection. Now, there are various parameters which can be generated from the CT perfusion images. That is the cerebral blood volume, cerebral blood flow, mean transit time, and Tmax. Now, the relation between these parameters are determined by this central volume principle. Now, coming to the interpretation of the CT perfusion images, now they can be interpreted just based on visual assessment of the parametric color maps, or there are automated softwares which help in interpreting or interpret these perfusion data, or the vendor provided maps which also can help in interpreting the data. Now, let's see an illustration. So this is a non-contrast CT angiogram, and these are parametric color maps of CBF, CBV, and mean transit time. So this is the automated software generated interpretation of the perfusion. Now there is a subtle early ischemic changes seen in the MCA territory. There is a M1 occlusion. Now if you look at the mean transit time map, there is a large area of elevated transit time. Now if you look at the cerebral blood flow is near normal, and there's a significant mismatch between the cerebral blood flow and the mean transit time. Cerebral blood volume, cerebral blood volume, I'm sorry. There's a significant mismatch between the cerebral blood volume and the mean transit time. So this suggests that there is a large penumbra. So here what we see is the cerebral blood flow is also reduced. Now the interpretation based on the automated software, the definition for a core is when the cerebral blood flow is less than 30% as compared to the opposite contralateral hemisphere. Now in this illustration, the calculated cerebral blood flow is 8 ml, and the definition for penumbra is what is taken as a T max of more than 6 seconds. Now in this illustration, the calculated penumbra is 85 ml. So the mismatch, there is a significant mismatch between the core and the penumbra. So this is an ideal case for revascularization. Now, the other advantage or other information which the perfusion imaging provides is a hypoperfusion intensity ratio. Now, this ratio determines the collateral status of a patient, and also it also has a prognostic implication. Now, if the ratio is less than 0.4, the collaterals are better, and the outcome or the results tend to be better. Now, how is this assessed? Is the Tmax of more than 10 seconds, the volume of Tmax at more than 10 seconds and more than 6 seconds are obtained, and the ratio of this is taken out. If the ratio is less than 0.4, then it means that the collateral status is good. This is an additional information which the perfusion data gives us. Now, there's one pitfall, especially when automated software is used. Now, this automated software usually uses cerebral blood flow for calculation of the core. Now, this assessment is fallacious, or this assessment is usually wrong when the infarct is slightly older, or when there is development of leptomeningeal collaterals. Now, in this illustration, we see a relatively well-established infarct, which is showing a perfusion defect on cerebral blood volume parametric map with elevated mean transit time, with a match between the cerebral blood volume and mean transit time. So there is no salvageable brain parenchyma. However, the automated map shows that there is no core with a 26 ml of penumbra, saying that there's a mismatch between the core and penumbra. So this is one of the pitfall of automated softwares which use cerebral blood flow for assessment of the core. Now, coming to MRI, MRI is far superior in assessment of the core because diffusion is one of the most sensitive sequence for picking up the infarcts at the earliest. Now, the diffusion changes are usually due to cytotoxic edema, which develops at the site of infarct due to collection or intracellular accumulation of the fluid due to sodium potassium ATPase failure. Now, flare, the changes in flare usually take some time to appear. Now, this is because from the time of this is because the time taken for the vasogenic edema to develop, which starts to appear on flare. So the difference between when there is a mismatch between the flare and diffusion, it always suggests that the infarct is hyperacute. That is, the infarct is the onset of time of onset is usually less than 4.5 hours. And the other utility of flare is what we see here is hyperintense vessels. Now, this flare is also useful in assessment of the collaterals. The SWI this sequence not only helps us to exclude the presence of hemorrhage, but also helps us to characterize the clot and measure the length of the clot. Now, here what we see is a susceptibility signal within the occluded MCA, suggesting a RBC-rich clot. And this also gives us an idea about the length of the clot, because the length of the clot determines the prognosis. It has a prognostic implication. MR angiogram, as a CT angiogram, will give us the arterial anatomy and confirms the occlusion of the blood vessels. So always the imaging includes both neck and intracranial, because in addition to the identification of the site of occlusion, we also will be able to plan our intervention based looking at the anatomy of the neck vessels, the arch vessels, and presence of tandem lesions or other lesions in the neck or arch vessels. Now, this is an illustration just to show the flare vascular hyperintensity, which is analogous to the collateral score seen on CT, with various studies showing that mismatch between the flare vascular hyperintensity and the diffusion tend to have a better outcome or a smaller final infarct volume. Now, the one very good or significant benefit of doing an MR is to pick up the stroke mimics. Now, this is an illustration which shows a 31-year-old male who presented with acute onset right-sided weakness. There was no seizures. However, his blood sugar levels were high at the time of admission. So there is subtle cortical hyperintensity which is seen in the parietal region. No visible changes on flare. However, the ASL shows an elevated perfusion. So this suggests that these are hyperglycemia-induced parenchymal changes in the brain and not a stroke, which is a usual stroke mimic. So timing of the infarct now, as already discussed, diffusion flare mismatch helps us to time the infarct when the onset of the infarct is, timing of the infarct is not known. Because there is always a time gap for the changes from the changes which have appeared in the diffusion to start appearing on flare. Other things which can be used to plan a treatment when the onset of infarct is not known is to look at the perfusion and core mismatch, which has been used in the trials like the diffuse-3 trial, and the clinical and core mismatch, which is again used by the Dawn trial in selection of the patients in within the extended window. Now, just to say a few words on how to select a patient based on the imaging. If the patient presents within 6 hours, he becomes an ideal candidate for endovascular intervention when he has a small infarct core, that is an aspect of more than 6. He has a significant clinical, moderate to severe clinical deficit, that is an NHS score more than or equal to 6, and there is a large vessel occlusion. Now, if the patient presents during the extended window, that is between 6 to 24 hours, if he has a large vessel occlusion, so within the 6 to 16 hours period, he should qualify the Dawn or diffuse-3 criteria. So the Dawn criteria is mainly based on the clinical core mismatch, where for a patient who is less than 80 years, who has an NIHS of more than 10, should have an infarct volume less than 31 cc, which can be assessed based on the diffusion MRI or based on the perfusion. And if he is more than 80 years, the NIHS is more than 10, the infarct volume should be less than 12 cc. For the diffusion, diffuse-3 utilizes the perfusion core mismatch criteria, where the infarct volume should be less than 30 cc and the ratio between the ischemic tissue and the core should be more than 1.8. And if the duration is between 6 to 24 hours or 16 to 24 hours, then he has to qualify the Dawn criteria. So to conclude, what I would like to say is that multimodality imaging is helpful in identifying the vessel vascular occlusion, irreversible, determining the core and the penumbra, which is the salvageable brain parenchyma, presence of the collaterals, and perfusion and MRI are superior in selection of patients when the time of onset of the infarct is unknown or during the extended window period. Thank you.
Thank you, Dr. Savit, for your nice illustration of different cases. So, can we, may I request Dr. Raghunandan Nadik? Shall we move to the next presentation? Dr. Raghunandan Nadik doesn't require any introduction to the audience of Karnataka Neurology Group. He is a professor of neurology at St. John's Medical College and Research Institute, and currently he is the in charge of COVID War Room. And I think many of you may not be knowing, St. John's runs one of the largest COVID hospital in South India. So amidst of his all busy schedule, he has accepted our invitation and he is presenting his lecture on medical management of acute ischemic stroke. Over to Dr. Nadik, please.
One second, I'll share my slides. 1 second, sorry. At the outset, I thank Dr. Suryanand Sharma and Dr. Vikram to host this webinar on stroke thrombectomy. So, 1 second, sorry. Can you see my slides? No. Okay, 1 second. Yes, I'll share it. Yeah. Okay. Yeah, I think you can see my slides now, no?
Yeah, we can see the slides.
Yeah, thank you. So I think before my talk, I think Dr. Amit had spoken many things about the pathophysiology clinical, and I think Savit has also spoken about the imaging. So what I will be talking is medical management of acute ischemic stroke, the acute management. So I'm not going to how to give thrombolysis and all, will not speak. So as we all know, so the main management in acute ischemic stroke is giving thrombolysis, that opening of the blood vessel and improve the perfusion and save the brain. So many things right from 1994, after the first NINDS trial, subsequently a lot of changes have happened and thrombolytics have been given. So I restrain my talk only to intravenous thrombolysis, what has been updated of late as latest as 2021. So I'll be speaking on what we know in AHA guidelines, then European Stroke Association, and I'll conclude my talk with few summary slides. As we all know, it was approved way back in 1996, but it was approved only for 3 hours. Subsequently, 3 to 4.5 hours, this FDA has approved only recently for a certain group of patients, whereas in our country and European, it is approved even up to 4.5 hours. So, but there is some problem with the Altiplase is that it has low recanalization rate and risk of intracranial hemorrhage, and as we all know, it has a short half-life, so that you have to give infusion, and the cost is quite high for a developing nation like us. And as we all know, I think Dr. Amit has told, so saving neurons as much as possible, so saving the core infarct and saving the penumbra by opening up the blood vessel. And as we all know, I think this all of us will know this, nearly every minute lost we'll be losing about 1.5 million neurons, about 14 billion synapses, and even 7.5 millions of myelinated fibers. So that what is the main concept is in medical management is to open the blood vessel as fast as possible and finding an ideal patient and knowing what drug to be given at what is the dose and what time, how to do it. So real world, really what happens is only 4% of people are receiving TPE. So that is what is real scenario. Even in 2020, 21, even this COVID, it has become even less. And even when we did a study, it is known that because of patients' delay, they don't recognize that they have stroke. So this is beyond today's talk, but this is one of the real world problems. So that even though they come, so the only 4% of patients who really have stroke, ischemic stroke, who are eligible for thrombolysis receives thrombolytics. So over a period of years, 2009, 10, then 2013, then 2015 and 2018, even 2019, the AHA has upgraded their guidelines and changed the guidelines. So as on 2018, so what are the guidelines? They say IV Altiplase 0.9 mg per kg, maximum dose of 90 over 60 minutes, initially 10% bolus is recommended for select patients who may be treated within 3 hours of ischemic stroke symptom onset or patient lost known well at baseline. And this has got class of recommendation 1 and level of evidence A. So this is updated as 2013, nothing has changed. So up to 3 hours, there is no controversy, 0.9 mg per kg of Altiplase can be given. So between 3 to 4.5 hours, so class 1 indication here, based on few recommendation, it is level of evidence B. There are certain conditions like if you have above 80 years, and then if you have a previous stroke or uncontrolled diabetics, you are not going to give thrombolysis. This is what is the AHA has told us. And this is the various recommendations of intravenous Altiplase based on the hours, 3 hours as I've already told. And within 3 hours, earlier, the beginning, they were telling beyond less than 80 years of age. So over a period of years, based on the observation and other trials, it was found that it is safe even after the 80 years of age. So now, whoever comes within, whatever be the age, within 3 hours, one can give, according to the AHA guidelines, you can give IV thrombolysis with Altiplase. And even with severe stroke, this was one of the relative contraindications earlier, but now they are telling that even with a severe stroke, that means NIH of more than 25, so the benefit, despite increased risk of hemorrhagic transformation, there is still proven clinical benefit. So one can even administer IV Altiplase even within 3 hours if there is severe stroke. And the other question was earlier, mild disabling stroke, they were not advising, but now one can also administer with IV TPA within 3 hours with a mild disabling stroke. And coming to this question of 3 to 4.5 years of age, so that is still AHA is giving a class class B indication, level of B indication. So 3 to 4.5 hours Altiplase window is recommended for those less than 80 years of age without history of both diabetes and period stroke and NIH score of less than 25 and should not be on any oral anticoagulants and without imaging evidence of ischemic injury involving more than 1/3. So this is what the NIH American Academy says. So this is how we administer IV TP. I think all this audience know how to give it and monitor blood pressure every 15 minutes and then obtain follow-up CT or MRI at 24 hours and then decide. So as told by Savit, all patients with suspected ischemic stroke will get both vessel wall imaging also. Apart from the CT angio, or if you're doing MR angio has to be done ideally, and don't waste time for vessel wall imaging, but definitely it has to be done. So subsequently, what has happened over a period of years, it was found that many patients with a large vessel occlusion, they were not improving with IV TPA. So though in 2018, the guidelines changed based on the few trial like rescue trial and all, it was found that patient eligible for IV TPA should receive IV Altiplase even if mechanical thrombectomy is being considered. This is the controversy now in few people who think, I think Vikram may address this, patients who are in a center where thrombectomy can be done, so you can directly go ahead with thrombectomy done IV Altiplase. This is yet to come, but as on today, one have to administer IV Altiplase even if you are contemplating mechanical thrombectomy. In patient under consideration for mechanical thrombectomy, observation of IV Altiplase to assess for clinical response should not be performed. So this is happening many times, whereas some neurologists feel that we give IV TPA, we'll wait and see whether the vessel opens, then we will consider thrombectomy. So no, as soon as if you see a person, so if you see a person who has got a large vessel occlusion, LVO, which Savit was mentioning, and having a pre-stroke score of 0 to 1, and MCA segment or a distal ICA, NIHS score of more than 6, aspects of more than 6, and treatment can be initiated within 6 hours of onset of time. If any of these things are there, even though you start thrombolysis, this patient has to be pushed for mechanical thrombectomy. This is the new guidelines which has been issued, recommendation from 2015. This is the 2019 guidelines. So all patients who comes to you who is an eligible candidate for thrombolysis, look for large vessel occlusion. If you find a large vessel occlusion, they should be pushed for thrombectomy. If you don't have that facility also, then ship and you can drip this patient and ship this patient. So that is what is most. So this is all the AHA guidelines. So subsequently in this European 2021, as of last 2 months, few guidelines have been issued. They have analyzed all the data, and there are certain questions which are asked, which are very pertinent to all of us. That is what I'm going to discuss in next few slides. The first question is treatment within 4.5 hours of onset. In patient with acute ischemic stroke of less than 4.5 hours duration, does IV TPA lead to better functional outcome than no IV TPA? So this is the standard question. So it has been found good, but that has been once again been questioned. And then we'll see the based on the current evidences. So as we know, level of evidence is more analyzing the meta-analysis which of the randomized trial that give a lot of correct data and then show the benefit. So there are two meta-analysis, one published in the Lancet by Warder et al. Nearly 6,800 patients. So the data of nearly 13,000 patients who have received a IV TPA within 4.5 hours, that data is there. So based on this, so the meta-analysis demonstrated that altiplase within 6 hours of stroke onset reduced the risk of death or disability, and the effect was greatest within 3 hours. So that is the most important. As early as you give, that is more beneficial. The individual participant data meta-analysis was consistent with these results. It showed that altiplase significantly increased the odds of excellent outcome at 3 months, with earlier treatment resulting in greater proportional benefit. So based on this, the recommendation for all patients with acute ischemic stroke of less than 4.5 hour duration, intravenous thrombolysis with altiplase is recommended. Quality of evidence is very high and strength of recommendation is more. So there is no doubt now for all patients who comes to us with a acute ischemic stroke within 4.5 hours, it will be wrong from our part if you don't offer them IV thrombolysis with altiplase. So the next question was, the person who comes between 4.5 to 9 hours after onset without the use of advanced imaging, what Dr. Savit was mentioning about CT perfusion, CT or MRI diffusion perfusion imaging, without doing that, but just doing a CT scan and then a vessel wall imaging, can we do a thrombolysis? That was the question with IV TPA, that is between 4.5 to 9 hours. And based on this, based on the evidence, it is found that without advanced imaging, that means if you don't demonstrate there is a diffusion perfusion mismatch or a significant penumbra, so it is not recommended to just give IV thrombolysis with altiplase after 4.5 hours within 9 hours if you have not done imaging or if you have not demonstrated the CT perfusion or if you have not demonstrated the penumbra. So the third question was, same patients within 9 hours with the use of advanced imaging. So that is means known onset of time, that is 4.5 to 9 hours, and with CT or MRI core perfusion mismatch, does intravenous thrombolysis with altiplase lead to better functional outcome than no intravenous thrombolysis? So this is the person who has done advanced imaging. So what do these studies have included? As she mentioned in the last slide, mismatch between non-contrast CT and perfusion, and mismatch between diffusion and perfusion weighted. So what has been shown here, the studies have shown that means the patients have been included in these studies are perfusion lesion ischemic core score mismatch of defined as a ratio greater than 1.2. And between the volume of hypoperfusion and the volume of ischemic core, an absolute difference in volume of greater than 10 ml, and in ischemic core volume of less than 70 ml. So all these patients who have any of these things can be done, undergo this the IV thrombolysis between 4.5 hours to 6.9 hours. So studies, these are the two important studies which are shown, ECAS-4 and EPITHET trial. Based on this trial, so and then another one trial which has seen is the EXTEND trial. I don't think I can go through all of these things. So these are the three trials which has found that patients who have undergone thrombolysis with altiplase between 4.5 to 9 hours. So MRS at 0 to 1 at 3 months is 95.4 versus 29 in placebo, and there was no evidence that effect was different in patient treated during different trial. And the risk of SH was higher in altiplase group. So based on all these things, what is the recommendation and then the data analysis is recommendation is, so 4.5 to 9 hours duration, and with CT or MRI core perfusion mismatch, and for whom mechanical thrombectomy is either not indicated or not planned, we recommended IV thrombolysis. Suppose if you want to do a patient's thrombectomy, there is you can go ahead with thrombectomy, not with IV thrombolysis. So if you don't have the facility, or if you are not contemplating, or if this candidate is not candidate for a mechanical thrombectomy, then you can give IV thrombolysis between 4.5 to 9 hours. Quality of evidence, even though it is low, center recommendation is strong. So this is a catch here. Person who has come to you between 4.5 to 9 hours, and if you are contemplating thrombectomy, please go ahead and do the thrombectomy. If you are not contemplating, you have done a perfusion diffusion mismatch and you demonstrate there is a significant penumbra. Suppose if you are not contemplating thrombectomy, definitely you go ahead and do the IV thrombolysis. So next, the same question is stroke on awakening from sleep of or unknown onset. So whether we can thrombolyze and what to be done. Here it is also same extension of the same part of the 4.5 to 9 hours. So there are two trials. The trial which was done is wake up trial. The trial excluded patients who thrombectomy was planned. So patients they didn't include. They analyzed only patients who were woken up and then they had a significant diffusion flare mismatch or a significant penumbra. And then altiplase was associated with a non-significantly increased risk of SIH, but a no significantly higher mortality at 90 days, but had an excellent outcome, adjusted over for excellent outcome with altiplase of 1.61. So based on and another trial is the TWAS trial, thrombolysis for acute wake-up and unclear onset stroke with altiplase at 0.6 mg used the same criteria for patient. This trial found no difference in excellent outcome at 3 months between the altiplase and the control group, and there was no difference for death. So this same trial which used the CT and MRI core mismatch and then analyzed the independent data also. So based on all these things, the recommendation is for patients with acute ischemic stroke on awakening from sleep who are last seen well more than 4.5 hours earlier, who have MRI diffusion flare mismatch, and for whom mechanical thrombectomy is either not indicated or not planned, we recommend intravenous thrombolysis with altiplase. So that is the recommendation. So if you are not planning thrombectomy, awake stroke, if there is a mismatch, one can give IV altiplase. Quality of evidence is high, strength of recommendation is strong. For patient with acute ischemic stroke on awakening from who have CT or MRI perfusion within 9 hours from the midpoint of the sleep and for whom mechanical thrombectomy is either not indicated or not planned, we recommend IV TPA. So the same thing can be administered. So expert consensus statement is also the same thing. If you are contemplating thrombectomy, go ahead and do thrombectomy. Don't give IV thrombolysis. If you are giving not contemplating thrombectomy, go ahead and do the IV thrombolysis. Now the fifth question. So always this time we were talking about IV altiplase. So what about the other thrombolytics like a tenecteplase? So the advantage of tenecteplase is it has got a higher fibrin affinity and longer half-life and can be administered with a single intravenous bolus injection as compared to the IV TPA. So can this drug be given? So many trials have been done from 2005 onwards, initially the dose and then subsequently the duration and the before thrombolysis in a large vessel occlusion. So a lot of trials are there, which I'm not going to that. There are some meta-analysis which was published from 2018, tenecteplase versus altiplase in acute ischemic stroke with systemic review and meta-analysis. Meta-analysis found tenecteplase to be significantly favoring one outcome, early neurological improvement. Other outcomes did not differ between tenecteplase and altiplase group. And subsequently, 5 randomized trial meta-analysis was done, and it was found that tenecteplase is non-inferior to altiplase in the treatment of acute ischemic stroke. This was published in 2019. And basilar artery occlusion also, it was found that tenecteplase is better. It has opened up the basilar artery and then outcome is good. So then finally, this is the recent tenecteplase study, intravenous with large vessel occlusion, a systematic review. It was found that the people who received a tenecteplase compared to altiplase had a better vessel opening in all the 3 things. One is in the successful recanalization and modified Rankin score of 0 to 2 at 3 months and functional improvement at 3 months. This is compared with altiplase to tenecteplase in patients with large vessel occlusion and who are undergoing thrombectomy. So, and as we all know, tenecteplase usage has been approved in our country, and then the trial which was done by multi-center study in India, so and published in 2018. So found that the TNK of 0.2 mg per kg administered within 3 hours of symptom onset seems to be well tolerated and effective option in patients with acute ischemic stroke. That is what is the conclusion. And this is the generic one which is available, what we have. And it has got 72 to 78% in standardized clot lysis assay as against to 97 to 100% from the innovator tenecteplase. So this is the study which was published, and based on this, our DGCA has given approval for so 0 to 3 hours. We have either IV tenecteplase or IV TPA can be administered. Between 3 to 4.5 hours, IV RTPA is administered, and they also include the same data as NIH, less than 80 years and no history of diabetes and previous stroke, and not an anticoagulation and NIH of 25. This is our Indian guidelines, which is published in 2019 in NPCDS. So this is what is currently is approved according to in our country. 0 to 3 hours, you have both. 3 to 4.5 hours is IV TPA. If there are if less than 80 years and no history of diabetes and previous stroke and not on anticoagulation. So the recommendation is, as I mentioned now. Now coming to the AHA, as AHA also has changed after this. They told choosing tenecteplase single dose IV 2.5 mg maximum to over IV altiplase in patients without contraindications for IV fibrinolysis who are eligible for undergoing mechanical thrombectomy. So that is the the Western world thinks tenecteplase, if you want to do a mechanical thrombectomy in a patient, so if you want to consider an IV thrombolysis, then please use tenecteplase rather than the altiplase. So this is a different thing I don't understand. So, but both can be used. But tenecteplase, why it is not better in 0 to 4.5? Only it is better in patients who are mechanical thrombectomy. That needs to be answered in future. So the other question is that is what is the question which was asked. With acute is less than, does IV tenecteplase lead to better functional outcome than IV altiplase? For this question, the answer is that to administer IVs with altiplase over intravenous thrombolysis with tenecteplase. So it is. So the recommendation is, if you have a ischemic stroke not undergoing mechanical thrombectomy, still the our ESO guidelines also says under 4.5 hours, it is better to give altiplase, not tenecteplase. So same thing, once again, the question here is the patient is indicated only if they are undergoing thrombectomy. The dose is about 0.25 mg per kg over intravenous thrombolysis than altiplase. So what are the other doses which have been there going next to the other drug is the dosage of altiplase. So there was a study, Enchant study, which showed that 0.6 mg is better in Asians compared to the 0.9. So the same question is asked, whether under 4.5 hours can we give a low dose of altiplase. After analyzing many of the data, the ESO guidelines have told that with acute ischemic stroke of less than 400 of duration who are eligible for IV thrombolysis, they recommend standard dose, not the lower dose of altiplase. Now, over a period of years, there are a lot of contraindications for there which have been removed from the that have become contraindication, and absolute and relative has been reviewed. So whatever that is written in the red, that has been removed, which are all absolute, which are all earlier contraindication for IV thrombolysis, like arterial puncture at non-compressible site in 7 years, elevated BP, because we can reduce the BP and thrombolyze it, and minor or rapidly improving was a contraindication earlier. Pregnancy, we can take call versus risk versus benefit. Seizure at onset, if you demonstrate that it is not due to hyperglycemia, hypoglycemia, you can take off. Major surgery with serious trauma, if you can control the bleeding, you can still thrombolyze. MI within 3 months was relative, now relative contraindication, and this age group has been removed, like more than 80 years, anticoagulation regardless of INR. And the new contraindication that is been added as in acute ischemic stroke due to infective endocarditis, one is not going to do intravenous thrombolysis. So in summary, what is the present medical management is, IVT with altiplase is indicated all acute ischemic stroke within 4.5 hours of onset if there are no absolute contraindication. IVT with tenecteplase of 0.2 mg per kg can be administered in acute ischemic stroke presenting within 3 hours from onset of symptoms. This is Indian guidelines. IVT with altiplase is recommended in patients with acute ischemic stroke between 4.5 hours to 9 hours after advanced neuroimaging demonstrating significant presence of penumbra. IVT followed by mechanical thrombectomy in AS is large vessel occlusion. This is always we have to consider. If planning thrombectomy, IVT with tenecteplase 0.25 mg per will be better than with Actilase. Thank you.
Thank you, Dr. Nadik. That was a wonderful lecture on medical management of acute ischemic stroke. I'm sure you touched upon various gray areas, and during question and answer, I think we'll have a lot of questions. As we are running short of time, we will proceed to the next talk. That is mechanical thrombectomy in extended window period. That is by Dr. Vikram Huded. I'm sure Dr. Vikram doesn't require any introduction to the august audience here. Dr. Vikram Huded is Senior Consultant Interventional Neurologist and Head of Neurology at Narayana Health. And currently, for today's event, he is actually All India Co-Chair for Mission Mechanical Thrombectomy Project. And he is the Vice President of Karnataka Stroke Foundation, which is hosting this event. Over to Dr. Vikram.
Thank you, Dr. Sharma, for the kind introduction. So mechanical thrombectomy in 2013, there was IMS3. After the IMS3 result, people thought that we should not do mechanical thrombectomy. And after that, in 2015, 5 trials came, and we changed the scenario for mechanical thrombectomy. In 2015, up to 6 hours, it was proved that we can do mechanical thrombectomy. And when they analyzed the Hermes data, there was no benefit beyond 7.3 hours duration. So in Extend-IA and Swift Prime, they use perfusion imaging for selection. So they had a better outcome. So the question is, could better selection based on imaging lead to better outcome in the extended window? So this will be my talk today. I started doing mechanical thrombectomy in 2010, where we used to give intraarterial TPA first, and if there was no recanalization, we used to use solitary thrombectomy device. But the results were fantastic, and I think with 2015 data, I think it has become a gold standard now. Coming to the mechanical thrombectomy, or already Savit and Amit explained that when the blood flow to the brain is blocked, there will be structural dysfunction in the neurons, which is a core, which is irreversible. And there will be large area of penumbra where there is electrical dysfunction, but structurally the neurons are intact. So earlier we used to think that that with time, that Jeff Savers, he told that every second we lose 32,000 neurons. But it all depends on the collaterals. So collaterals are most important thing in saving the brain or preserving the same brain till we reperfuse. So if there are no collaterals, there won't be any penumbra. So even within technicality in imaging, and also the devices will help if the collaterals are good in that patients. So even demonstrating collateral is not important. For example, if core is small and clinically if patient has got large NIHs or more than 6 or 10, then we know that this patient has good collateral and there is a mismatch, and we need to do thrombectomy for these patients. Okay, so there will be some patients who worsen faster, it indicates that the collateral is not good. Where there are some patients, around 15 to 20% of patients, where the infarct extends slowly. So because they are good collateral. So these patients we need to identify. So these trials, it showed that we need to document the vessel occlusion before thrombolysis. Whereas in IMS3, they didn't document the vessel occlusion. That's why it was a neutral trial. When you document the vessel occlusion before thrombolysis and randomize, you have to do recanalization early and better recanalization with a newer device, the outcome was significantly better. So that's why it has become gold standard for means we have to do mechanical thrombectomy in a large vessel occlusion. So there is a trend towards even reducing the mortality in these large trials. So coming to the Dawn and Diffuse, which was extended window period for thrombectomy. So it is important that you need to identify these patients. So if a patient comes to you from 6 to 16 hours window, better to use diffuse criteria, because we may include a large amount of patients because the NIHs in diffuse is 6. Whereas if a patient comes between 16 to 24 hours, better to use the dawn criteria because the diffuse used up to 16 hours. So in our hospital, if a patient comes between 6 to 16 hours window, we use diffuse criteria, whereas more than 16 hours, we can use dawn criteria. So coming to the imaging thing, already Savita has told, see, many people will ask when we should do perfusion imaging. Like if a patient already infarct size is more than 1/3 of MCA, we can't extend the window beyond 6 hours time. So in those patients, we can't do perfusion imaging, or it is not required, or we can't do mechanical thrombectomy. So the basic imaging criteria is the infarct size should be less than 1/3 of the MCA territory. Then we can do perfusion imaging, and depending on the core and the clinical mismatch in dawn criteria, or perfusion criteria like less than 70 ml core, mismatch volume, and mismatch ratio. So we can take such patients for mechanical thrombectomy. So these are all contraindications because so they wanted to select good cases so that we know that it is effective. Both dawn and diffuse showed a functionally very good outcome compared to the control group. The risk because of the bleed and all, it was not significantly more. Even in diffuse, the functional outcome was better. So with these, based on these results, AHA, they changed the guidelines that if a patient comes to you with a stroke, and if you suspect it is a large vessel occlusion, if they fulfill the dawn and diffuse criteria, then we can do mechanical thrombectomy up to 24 hours time. I think in future, the window may extend to 36 hours or 48 hours, because it is mainly imaging which is helping us in deciding the patients, even though in the dawn, they use clinical and core mismatch. Okay, so I will be showing few examples how we can do 65-year male hemiparesis 12 hours duration and NHS 12. So you can see that the infarct volume is less than 1/3 of MCA territory, and there is a large vessel occlusion, ICA and MCA. And so in those patients, we do perfusion imaging. So even though there are limitations in perfusion imaging and automation, this is a very useful tool, because you get the report to your mobile in 5 minutes time. I think analysis is fantastic, and so it will tell us what is the core, which is 14 ml, and it will tell the mismatch volume, which is the penumbra, and the mismatch ratio. So this patient, it is fitting into the criteria. So this is IC occlusion. We retrieve the clot. There was a cavernous stenosis. So it was re-occluding. So that's why we need to put a stent, coronary stent, to keep the lumen patent. So that's why, so 24 hours window is a huge window. I think recently we had a patient who traveled, one of the neurologist cousin, who traveled from Ballari to here. So, and he reached in 12 hours window. So the time of 24 hours window is a huge, and I think we should be creating more awareness about it, and we can do more thrombectomies and help the patients. So, and this is what I was telling. So the collaterals are more important. This is a 40-year male. He had a recent anteroval MI and developed stroke, 2 hours window, NHS 14. And see, in 2 hours already there is no penumbra, and the whole brain is infarcted. And repeat scan within 24 hours, there was a midline shift, and the patient did not wanted decompression craniotomy. So that's why the most important thing which will help the patient, or which will improve the outcome, is the collaterals. If collaterals are good, we can help those patients who will worsen slowly up to 24 hours window. So over from January 2017 to May 2019, we had 846 stroke admissions. In that, 461 came within 24 hours window. We had done around 84 thrombectomies, And based on rapid analysis, which is out of 461 patients, we could get only 13 patients. So that slow progressors volume will be very small unless a patient is selected that it is a large vessel occlusion and MCA infarct is less than 1/3. If such patients are selected and referred, then only the volume will go up. So the mean age is around 45 years. So they are younger patients in India. Mechanical thrombectomy compared to outside India, the mean age is lesser. So NHS, median NHS is around 14 and aspect is around 7. So core volume is around 18 ml. So all of them are small core. Median aspect is 7. So the average timing to get the report after perfusion imaging in the software is around 5 minutes time. So recanalization was around 92%. Perfusion to recanalization was 40%. The overall good outcome was seen in 46% of patients. Good outcome is better if there is a significant mismatch and reperfusion is means door to puncture time is less and puncture to recanalization is a lesser time. So this slide is important because the evidence for mechanical thrombectomy already Savit told and Amit also told is very strong compared to even primary PTCA for MI. So for MI, when we do PTCA, the number needed to treat is around 22. So in mechanical thrombectomy, when we select cases very carefully, the number needed to treat is around 2.6 to 2.3. So almost 1 out of 2 patients will get a benefit. So that's why it is important that we need to select these patients, and endovascular treatment can be extended up to 24 hours time in patients with large vessel occlusion. Thank you.
Yeah, thank you, Dr. Vikram. That was a wonderful lecture. Every time you give lecture on mechanical thrombectomy, you come with new data, new ideas, and new information. We will take the questions later. Now we have Dr. Dilip Yavgal, who is our guest speaker to deliver his keynote address. May I request Dr. Guru Prasad, Senior Consultant Neurologist, to introduce the guest speaker. Dr. Guru Prasad. In a very short notice, Dr. Dilip Yavgal has accepted our invitation and he has agreed to participate. Dr. Guru, please go ahead.
Yeah, it gives me immense pleasure to introduce Dr. Dilip Raghavendra Yavgal. Address. We know that early morning in Miami. Thanks for accepting to give this keynote address for this afternoon's talk. It also gives me another reason to be happy that we share both our alumni from KM Hospital, Mumbai. He's presently Director of Intervention Neurology and Co-Director of Vascular Surgery, Director of Neurological Stem Cell Platform, Interdisciplinary Stem Cell Institute, Clinical Professor of Neurology and Neurosurgery, University of Miami, Miller School of Medicine, and Jackson Memorial Hospital, Miami, Florida. He has numerous awards and publications. He's the founder and global chair of the Mission Thrombectomy 2020 Plus, that is MT 2020 Plus global campaign, and for which reason we are having this webinar. He's been spearheading this movement, and hopefully we'll have much more awareness build up with this thing. Grant funded research in the translation of interarterial delivery of cell therapy for stroke. The international thought leader in endovascular therapy for ischemic and hemorrhagic stroke, as well as he's the co-founder and past president of the Society for Vascular Intervention Neurology, that is Society of Vascular and Intervention Neurology. Dr. Dilip Yavgal, please.
Thank you so much, Dr. Hazurkar. That's a very kind introduction. It's really a pleasure. Ellargu namaskar ಮಾಡ್ತೀನಿ. It's pleasure to speak in Kannada anytime I get a chance. But thank you, Vikram, for inviting me. And over the next 20 minutes or so, I want to really talk about Mission Thrombectomy 2020, especially as it applies to India. So what these are my disclosures. I have consulting relationships and grants. I don't have any patents on any of the thrombectomy devices. So I want to talk about why we are doing the global campaign, the mission vision, and the current organization, and what this means for the global unmet needs, and just talk a little bit about an exciting program that's collaboration between Mission Thrombectomy and Medtronic that's actually coming to India, as you will see an announcement later today. So again, the funding for MT 2020 Plus has been growing since 2016 when we launched, and we are very fortunate to have a robust funding this year. We had a gap year due to the pandemic. So the burden of stroke is quite massive, and really the bigger issue is that it is disproportionately burdened on low and middle income countries. This is actually 2010 number, but the more recent number from 2017 is 13.6 million strokes. But most of those strokes are really in Asia, in Latin America, in Russia, and this creates a scenario where we are not making a difference in the global disability that stroke creates unless we address low and middle income countries. What we do know is that mechanical thrombectomy is one of the most powerful therapies in medicine now. Since 2015, this has been very clear, but most recently, Brazil showed that this is really also very much the case in low and middle income country like Brazil. And so we are really quite fortunate that we can now offer a cure in a lot of truthful ways. We can call it a cure because we can truly reverse paralysis. We have clear evidence that the number needed to treat for this therapy is only about 2.5 in most cases. But more importantly, this therapy is highly cost effective. So there is a big upfront cost, but the cost of the subsequent disability that can go on for decades, especially in as Vikram was mentioning earlier, in a productive age group patient, that cost of decades of care for a disabled patient, loss of productivity, and the social and emotional impact far outstrips the initial cost of the procedure. And this is a analysis from Saudi Arabia. All the other analysis from high-income countries have clearly shown the procedure to be cost-effective, but from a low and middle-income country like Saudi Arabia, they projected a saving of over 600 million if the modern treatments like thrombectomy were implemented in their system. So initially the costs rise, but then the cost savings really take over. And so the fact that we have a very effective and a cost-effective therapy really means that we are obligated to bring this to our patients. But what is also clear that even in high-income countries and a leader in thrombectomy like the US, there is only about, in 2016, 20,000 thrombectomies that were done, and these are now up to around 45,000 thrombectomies, whereas the estimate of LVOs in the US itself is above 200,000 large vessel occlusions. If you start to include middle vessel artery occlusions, it's probably 50 to 75,000 more. And even in the US, we have only reached about 1/4 coverage. And in the global scenario, if you take 10% as the conservative estimate of LVOs, we are right around 1.3 to 1.7 million, depending on the 2007, 2010, 10 numbers, and the number of thrombectomies in worldwide were just under 200,000 in 2020, or I should say just above 200,000. So we have a long ways to go to cover this gap, and this gap is really exaggerated in Asia. And that obviously includes India. You can see that the red represents NOR, limited EVT and IVT, and that's in many parts of Asia. But most of Asia is orange, which is limited EVT and consistent IVT. Thankfully, the intravenous thrombolysis has gotten better, but the EVT is severely limited to single-digit percentage coverage. And this is, as we said, not just a low and middle income country problem, not just a Asia problem, but even in Europe, there is only 1 in 3 patients has access to an acute stroke unit, not even thrombectomy. And a paper just came out of the US that even in the US, only 1 in 6 patients are really able to get access thrombectomy in a timely manner. So we have a major thrombectomy gap, and this is exaggerated by the fact that the therapy is time sensitive. And a recent modeling from 2019 showed that for 60-minute ground access, 63% of the US population, we need 20 additional optimally located CSCs. So the problem with getting the right patient to the right center within the golden hour really needs a lot of infrastructure investment and planning. And what's also true is that any new therapy like this actually takes a long time to penetrate. This is a paper from 1964 by E.M. Rogers that showed that for 50% penetration of an innovation, whether it's health innovation or technological innovation, can take 30 to 40 years unless we intervene actively. And you can see that this number in the US of thrombectomy has steadily grown, but it's starting to plateau, which is to be expected. And we were hoping to get to 70,000, but we are nowhere near to 70,000 in 2020. And worldwide also, this number did go up initially, but we are only just above 200,000. I think we met the goal of 2020 for Mission Thrombectomy 2020, but we are, as you can see, slowing down as compared to the previous increase. And so without active interventions, it's very likely that the increase in thrombectomy access is going to slow down. There have been multiple efforts for a global response in stroke care, and these have been really mainly in the preventative arena. And we, as an interventional society in 2016, decided to put our weight and effort behind making thrombectomy a global effort, thrombectomy access a global effort. And our vision is the following. We don't want to replace any local or international efforts, but we are a campaign, a nonprofit campaign that is global, that's metric driven. We want to double thrombectomy, and an umbrella campaign. So we want to join hands with all other campaigns to reduce death and disability associated with LVO ischemic stroke by accelerating, by really rapidly increasing access to mechanical thrombectomy. And how do we want to do it? We want to do it more with public health interventions, integrating the disparate knowledge of barriers to thrombectomy access, to unify multiple efforts by local and specialty societies, and to use public health interventions, I'll talk about that in a second, to globally double the access to thrombectomy every 2 years. And what we are really aiming is that curve of 30 to 40 years can be cut down to 15 years or less in both developed and developing countries. What we are targeting are these very well-established access to treatment pillars worked out by researchers over the last 30, 40 years. And one of the researchers is a prominent business school professor from the University of Miami, Dr. Arun Sharma, who has worked it out that intuitively the barriers are around information access, where both specialists and general practitioners as well as emergency physicians need to know the information about LVO and triage. Physical access, ability to access facilities and specialists who can perform thrombectomy, and then financial access, which is clear without the payment, this procedure cannot be sustained. And what we hope to do is use upstream interventions that are economic, political, and community-based to target these three pillars of access. Of access. And so the idea is that a public health intervention can work to increase access when there is a large health burden that's getting larger, which is what stroke qualifies for. The burden is unfairly distributed. So even in a low and middle income country, the the poorer populations are more affected. Poverty is linked with stroke, and clearly globally, low and middle income countries are disproportionately affected. There is now a highly effective and safe treatment, and the treatment is cost effective, as we talked about. And there must be evidence that upstream strategies, which is government interventions, economic interventions to increase access to treatment, are not yet in place, and there is a tangible societal cost, which we, as we all know, these costs are starting to exceed $100 billion just in the US for stroke in the current era. This is the structure that has been built over the last 3 to 4 years for Mission Thrombectomy 2020. We have a core executive committee of 9 interventional neurologists in the US that really have dedicated themselves to building the public health intervention infrastructure for a global campaign. And we work very closely with global co-chairs, including Dr. Sailaja and Vikram and a number of others who are well known around the world from each continent. And then we have US liaisons to each of these countries, but most importantly are the regional committees. These are committees in the given region. So for example, there is a South India Regional Committee that has a stroke neurologist co-chair, a stroke interventional co-chair, and 6 to 8 more members who are stroke and interventional neurologists, but they can also include public health specialists, health ministers, ministry personnel, and stroke nurses. We have a very robust administrative support from the SVN administration office, as well as a very excellent project management team called Orbis that's actually based out of India. And we have really been fortunate to build 85 regional committees around the globe, including 82 in, the penetration is on all 6 continents, and 40 of these have had at least their first meeting, and more than 30 have had about 5 to 6 meetings to discuss implementation of increasing thrombectomy access. This is really the exciting progress in India. The national co-chairs for thrombectomy development through Mission Thrombectomy 2020 campaign are Vikram, Dr. Sailaja, and Dr. Padma Srivastav. And from the US, Dr. Kaz Asif and Dr. Nabil Hariel have been highly active collaborating with the All India Regional Committee. And then we have 5 committees in India that work with the All India Regional Committee: North, West, East, South, and Central. And you can see the co-chairs, which are all who are all very well-known leaders in India in stroke and intervention. And this is really a tremendous progress, or tremendous step forward, and very close to my heart, having studied in India and done residency there. I am very very aware of the stroke burden, and I think this is a big step for the stroke patients in India, where a very organized effort using a roadmap is going to make thrombectomy available over time to each and every stroke patient. The roadmap that MT 2020 has recommended to all the regional committees is to complete their roster, and it obviously always takes time, but now it's much easier with the virtual platforms. And the biggest thing is to disseminate a white paper that MT 2020 Plus has written last year for health policymakers. And I'll show you that in a second. This is a paper that educates health policymakers on why thrombectomy is important and how to build thrombectomy systems in your region. There is a survey that was completed that will be presented today for the very first time in detail from India and from all around the globe about the regional capacity for thrombectomy access as it exists. And then the committee is really tasked with a huge responsibility of developing top 3 to 5 public health interventions every year. that will make the biggest impact in that region in increasing access. We have really been very fortunate despite the pandemic. We've had 1, 2, 3, 4 symposiums, and we launched in September 2020 the 86 regional committees. The virtual meeting platforms have really made this global initiative have been able to have these meetings. We published the white paper on the last World Stroke Day on October 29th. And we had the survey completed, and we developed an app, and we also launched a stroke coordinator committee. Now I know I'm running a little behind time. Do I have another 3 to 4 minutes?
Yeah, please.
Yes, please go ahead. Yeah.
All right. So this is the white paper that was put together by the Global Executive Committee of Mission Thrombectomy 2020 that now has over 500 members globally. We are really proud that we have such a huge network, and with everybody's input, we published this this white paper, Stroke Mechanical Thrombectomy, Building Thrombectomy Systems of Care in Your Region, Why and How, a white paper. And this is written for health policymakers, so in non-technical language, very, very accessible to any non-medical person, that is highly referenced and runs into over 80 pages with the references, but really the synopsis is just about 4 to 5 pages that educates health policymakers on why they should have thrombectomy systems prioritized in their financial investments and health policy investments. We've also developed a very exciting app that has undergone several advancements that allows a given interventionalist in any corner of the world to log their cases in about 30 to 45 seconds in a de-identified manner with a drop-down menu on their smartphone. And that gets tagged. You can see there is a hospital in Alexandria, Egypt, that we can see a case has been done. And what the app allows is for the cases to be tracked in real time as soon as they're entered. Anyone in the world can see that in NH, for example, 10 cases were done in the last 3 days, and it's only the number that pops up, no identification, no details. The details are available to the interventionalist and on their own phone, but everyone else can just see the numbers in the different centers. So you can pretty much go from Bangalore to Karnataka to India to Asia and zoom in and zoom out, and you can really get all the numbers. The main requirement is that practitioners enter their cases. And so we are really in a very accelerated phase of MD 2020, where multiple regional committees around the world are implementing the roadmap and increasing the uptake of the app. So we'll build a very robust tracking of thrombectomies in real time globally, and our goals are only increasing with increasing partnership and funding. We are looking to establish a training framework that relies now on advancement in technology with virtual proctoring across country borders, and we want to incorporate mechanical thrombectomy into global health policy, including the WHO. We are increasing grant funding to MT 2020 through foundations, and the grant applications are already in process. We are increasing administrative support to local regional committees so that a number of these activities can be supported by administrators and not fall only on MD volunteers. Public education support is one of our biggest goals. So we are going to support regional committees for public education, and research continues to be key in driving MT 2020 forward. We are developing a mechanical thrombectomy access score. So we're going to be able to quantify a given region, a given city, or even a given village, a rural district, what kind of access they have and how it can be improved. And measurement and tracking, as I told you, and then high income country roadmap is being developed. A advanced country roadmap is being developed for the higher income countries that have slightly different needs. And then global certification remains a major goal, so we can certify thrombectomy centers around the globe. I think I will just finish in one more minute. I'll go through this a little fast, just in the interest of time. So from November 17th to February 28th of this past year, 2020 to 2021, we did a global survey of the thrombectomy capacity, and we had 887 respondents, 681 were complete, and they were from 43 countries. And you can see here, if we just looked at the responses, they were really global, all from each continent, and they came from radiologists, from interventional neurologists, from neurosurgeons. But really, interventional neurologists are starting to become a big proportion globally, and then stroke neurologists clearly were the biggest responders. And you can see India actually compares how many centers perform mechanical thrombectomy, that's in green, and India listed 156 centers. And how many operators in your country? India listed 239. And that doesn't compare too badly with a number of other countries. Certainly the gap is very quick to be apparent between India and the other high-income countries. But the point is that even just 2-3 years ago, these numbers were a lot lower. And when you look at other countries, also the number of procedures is an important metric. And India did 4,000 procedures as of 2019, pre-pandemic. So sorry, I take that back. 2019, which is the light green, 2,180, and they're projected to go to 4,000 in 21. So a doubling is what we are pushing for with the MT 2020 initiative in India, and looks like that's what's projected. But that number is far away from the 51,000 number that is projected for China in 21, 44,000 for the US, and Japan is 16,000. So big gap that needs to be covered, and the Indian people need this access very, very acutely because of the burden of stroke in India. And we asked the practitioners what are the top interventions, public health interventions, and you can see dark blue is high, and so different countries reported different ones. And I think I have India, or I had India here. I apologize, but really one of the biggest top interventions were health practitioner awareness and guideline implementation and hub and spoke mechanisms. And then physician training really was very high, is what I remember from India, which is clearly very much needed. The major obstacles have been identified by various studies. In Asia, treatment cost is clearly the top one. Low number of interventions, lack of EVT centers, and lack of defined acute triage systems. And MT 2020 is really focused to help with each of these barriers. And we are partnering with Angels, which is well known in India, Medtronic. We have the immediate partnership coming, and we really hope to influence the health ministries all in India, as well as in countries around the globe, to prioritize thrombectomy. I'm going to finish here very quickly. This is going to be discussed very much in more detail later today at the MT 2020 meeting, if you're going to join. But this program is bringing tremendous resources with a partnership with Medtronic to do a patient pathway assessment, and this is coming to India. There is going to be an educational program developed for all stakeholders, from nurses to technologists to referring doctors, and adjacent technologies like the Viz AI, Rapid, will be supported for different stroke thrombectomy centers. And most importantly, a stroke care economic analysis will be done in a given region and taken to policymakers to show the cost effectiveness in their region. And this will be continuously monitored over year over year, but with an assessment, identifying key gaps, defining high impact actions, and monitoring success. And so in conclusion, without active PHI, without active public health intervention, mechanical thrombectomy may take mechanical thrombectomy may take several decades to reach high levels of access. MD 2020 is a global campaign to accelerate thrombectomy access, and we aim to double the rates every 2 years. The white paper is going to be crucial to disseminate to health policymakers, especially once the pandemic is behind us. And 86 regional committees have really taken this this mandate forward for us, including in India. And annual PHI development will help us achieve our goals. Thank you so much.
Thank you very much, sir. That was a beautiful, roadmap what you have created for MT 2020 Plus project. I'm sure there are questions. Dr. Vikram, can you take some questions?
Yeah, I think there is one question specifically for Dilip. They've asked,
yes.
Do you think in the near future, with the refinement of intervention, IV thrombolysis may be a thing of past and all the strokes may be benefited by MT?
I think it's not going to get there at least for 10 more years. The ease of IV TPA really, I think, drives the need for that to be available. As research shows us, and as devices become smaller and smaller, I think we'll have more and more thrombectomy, but I do not see IV reperfusion going away. It's only a matter of another more powerful drug that's safer that can be given IV, and IV is IV. You just put an IV and you open the artery. If that happens, it's never going to go away. It's not happened yet, but I think we shouldn't give up on it. But the fact is that thrombectomy is here to stay for sure, and it's only going to increase.
And thank you, Dilip, for the excellent talk. So in the US, you told the number of mechanical thrombectomy is around 45,000 per year.
Right.
Looking at the India's population, around 3,000 to 4,000 strokes are happening every day. In that, if we take around 1/3 to be due to large vessel occlusion. So we are looking at the numbers to be around 3.5 lakhs mechanical thrombectomies per year. So if we take US number 1 lakh, for 1 lakh you are doing 40,000. So we should be doing around at least 1 lakh thrombectomies per year. For that, the number of neurointerventionists available is only 200.
Yeah.
Whereas for 40,000 thrombectomies, you have 900 neurointerventionists. Right. And for 1 lakh thrombectomy, we have 200 neurointerventionists. So how to increase the number? Even if
I think we have. I'm sorry, I do have to run to the MT 2020 meeting that's starting in just a few minutes. So I apologize for interrupting, but I really think that for our patients' sake, and I'm going to say this loud, and some people are not going to like it, we have to break our traditional barriers. Japan, just 6 months ago, totally changed their licensing. They allowed a number of practitioners who were not neurointerventionalists to go proctor, observe, and only if the neurointerventionalists signed off, they got immediate privileges to do thrombectomy. There's no way, as you just pointed out, we're going to cover these thrombectomies with just the handful of us. I know cardiology is always something that is controversial, but I think we cannot do without other practitioners coming in. It'll take us a century to help our patients if we continue on our traditional path.
Thank you, Dilip.
Thank you so much,
Professor Dilip.
I really appreciate it.
Thank you very much.
A very happy World Stroke Thrombectomy Day to all. We are really in a new era, and I cannot tell you how much we appreciate the partnership, and I do hope Karnataka leads the way in implementing thrombectomy. Thank you. Bye
bye. Any more questions? Can we take some more? Amit, can you take 1 or 2 questions here?
I think one of the questions was asked by senior neurologist, and the question was whether we should do a DSA in the patients whom we have done thrombolysis. I think the answer to that is that initially when we are doing a CT with CT angiogram, so we are doing a CT angiogram which will tell us whether it's an LVO or not. So if it's an LVO, it obviously means that even post IV thrombolysis, we need to confirm whether it is recanalized or not, because there is something called as deterioration following improvement, so DFI. So this can happen even when you go to bed thinking that you have recanalized the artery. So it's very important that once you do the thrombolysis in a known case of LVO, we must do a DSA to confirm whether the thrombolysis is successful or not. If not, we have to do a rescue thrombectomy. So that is the answer to this question. I have a question to Dr. Vikram, and this is about the, because in a country like ours, I'm sure, I think we all are seeing that most patients with large vessel occlusions are not able to, get the access to the right institutes at the right time. And secondly, the cost factor which is involved. Can something be done through any of the MT 2020 or through any of the NGOs, that there can be some funding done to ensure that these LVOs are treated on time and they get access to the right treatment?
Yeah. So Amit, in this MT 2020, it started from 2017. Actually, since 1 year now, the program is taken active part. I am one of the co-chair for All India, and so now state-wise we want to make people who are interested to increase the number of thrombectomy access. So in that way, we have done a survey. I think today in 2 hours time, I will be presenting that. And after that survey, now we have made a white paper, and that we need to communicate with the government. And through that, we want to come with a package which is suitable both for government setup and private setup. That is one thing. And we are approaching NABH to do a stroke central certification or thrombectomy center certification, because it is important that an ambulance that needs to reach to the particular hospital which has a thrombolysis facility or thrombectomy facility, that is in pipeline.
Dr. Nadig, you have anything to add?
No. Actually, the real cost, even in our hospital, when they reduce, the consumable itself will be cost about 2.8 lakhs to 3 lakhs. Even with a subsidized rest, there is no, they don't have taken not even 1 rupee in the pharmacy. Means like they bring it and all. So that is what is the real cost. So
Correct,
we had a thrombectomy is about 4 minimum. Even our doctors have not charged 1 rupee also. The consumable that what is that? So I think Saikant is here, he will know. So we have not charged anything. Even our hospital pharmacy has not taken any money, but still it. And outcome in the stroke, see, it is not like MI thrombolysis or you put a stent, because nobody knows what really happens. EF of 30, they will be walking little breathless. So in our weakness may not improve, the patients will be all, that is the outcome. So we would have saved brain, but that outcome may take 3 months to see. That I think we should educate the people. Education is more important. Like this COVIDology, what is going on in WhatsApp, the same thing about the thrombectomy, and the concept that it takes 3 months for them to improve, up to 1 year stroke can improve. You don't have a magic. That needs to be going to the community. That there is something, but you have to wait. And then it's because all of us will attribute money to the outcome. Now everybody is running behind tocilizumab and think that is wonder they will sit and walk oxygen. They don't know that. Like similarly, we should educate. Education is most important. And then, as Vikram was telling, we should train more people. The neurology residency, there should be a program where we don't want them to do aneurysm coiling, AVM and all. They have to do DSA and mechanical thrombectomy. That needs to be inculcated, and like us, all cardiology PGs comes out with a degree where they are entitled, that all neurologist PG henceforth should have it. And we should encourage it, and then that is where we can come up with it. Like we can overnight until over a period of 1 or 2, 3 years, we can have more neurologists getting intervention. And the cath lab can be used. Every district has got a cath lab.
Right. Yeah. The main thing is the cost issue. In India, we are doing around 2,000 procedure per year. Okay, whereas the potential is 3 lakhs procedure. So unless we get the volume, the company will not reduce the cost. So that's why through MT 2020, we are negotiating with the Medtronic to give a package. And also now government schemes are coming. Even I think, for example, Ayushman Bharat for liver transplant, government is ready to give 10 lakhs.
Even Ayushman Bharat covers, Vikram, 1 or 2
No,
patients we have
Ayushman
done.
Bharat mechanical thrombectomy cost is lesser, whereas Ayushman Bharat liver transplant cost is 10 lakhs. So I think that's why it is important that
policymakers come into a big play.
Policymakers.
The white paper is for the policymakers. Definitely, they can look into the costing, and
Correct.
once we have more numbers, definitely the cost will come down.
Correct.
There is a question, I think, which is given by Dr. Shobha. What is the rate of reocclusion in COVID strokes with mechanical thrombectomy? I think any panelist can take that. I think Dr. Vikram would be the right person to take that.
Yeah. Hi, good evening, Shobha. Actually, mechanical thrombectomy in COVID patients, we have done very few. I think it all depends on the mechanism. If it is a thrombotic, I think there is no reocclusion rate. And even sometimes IV thrombolysis, the recanalization is better. So I think the data is very small to comment what is the rate of reocclusion. In India, overall, I think our paper is accepted in annals for rescue stenting, specifically looking into rescue means post-thrombectomy reocclusion rate. I think in the next edition of annals, we'll be publishing it.
One of the audience has asked about public awareness during the pandemic. I feel that it is more important to create public awareness during the pandemic, because everybody gets carried away with only COVID, and nothing else. So we are having a lot of other patients dying of other non-communicable diseases like myocardial infarction, stroke, and other things. So in a pandemic situation, it becomes even more important for us to stress upon the fact of the stroke, mechanical thrombectomy, or even stroke as a treatable condition. So it's the responsibility of all the neurologists to raise the awareness in this regard. Dr. Guru Prasad, you have anything to add?
Basically, I think even the training also for intervention and thing also needs to be standardized. I think it should become part of the neurology training, at least the basics, like the cardiologists have some basic training in their DM. So we need to also push for it. Basically, if not the institute where they're training, but at least they can be posted for 2 months, 3 months to get a basic thing like puncture, understanding of the angiogram, all those things. So that should be grained into, so that when they come out, the interest should already be seeded. So once that happens, then we'll have much more neurologists who are ready to take on stroke management and stroke thrombectomy. I think that's where we need to create the manpower. So ultimately, other fields, the manpower can happen gradually, but for stroke, it's an enormous number. So unless we create manpower, whatever you do, it may not show the fruits unless you have good amount of stroke people, who are ready to do the mechanical thrombectomy.
Correct.
We have Professor Mehandiratta here. Sir, can we have some inputs from you about the program and how to take it forward in Indian subcontinent?
Thank you so much, Surya, for that. It's very kind of you. I'm an outsider today.
Nothing, sir. All neurologists in India are one family.
Yeah. But I want to specifically mention, like, when I shifted from government institute to private sector, I think in private sector, I always say now. Earlier, I used to talk. Now I walk the talk. Even today, we had a case for TPA and thrombectomy, but was not suitable. And many of the patients, even in private hospital, which can afford, they are like those who have the insurance. Because a recent onset insurance covers it. But still they say no because it costs heavy amount. So in short time, in my stint in BL Kapoor Max Hospital, in last, say, 4.5 months, I may have seen around 50 to 60 cases of stroke, and at least 20% have been thrombolized, ischemic stroke have been thrombolized. And 3 or 4 mechanical thrombectomy have been done. We have Dr. Amit Aslam, interventionist, who does this. And it's because of why we have code white in our institute. And I'm really enjoying that. The other thing I'm observing is it's beyond empty. It's beyond empty. Is that very good number of cases are coming is posterior circulation stroke. And also finding more and more. Today also had one case, one is admitted and one day before. There's a paraventricular infarct, which is like in the medial aspect of corona radiata. And with confidence, I go and tell the patient, you will make recovery within 2 weeks, don't worry. And that's what's happening. They are not COVID positive now. They had COVID in the past, say around 4 to 6 weeks back, and they are coming with those infarcts, which show today a patient who came, by the time was coming to the hospital, NIHSS was 1. So obviously we will not give TPA or tenecteplase in that. Tenecteplase is in place in our institution. So this was a very educative program, and I was very excited to listen to Dr. Amit Kulkarni, Dr. Vikram Huded, Dr. Yavagal, and Dr. Raghunanda, sorry. So I really enjoyed, and I assure you will also practice more and more. It's already being done actually. Now, as soon as patient comes, they don't do CT, they go for MRI somehow, I don't know, in our institute. First is MRI protocol. And similarly, by the side, when they are preparing a patient needs TPA, CT angio is also done. And we try to find out, which Amit was saying again and again, in addition to diffusion, perfusion weighted images, we also try to find out whether the candidate is suitable for MT. So all this protocol is done very fast. At times, patient gets MRI within 20 minutes after the arrival. That's the door of the hospital. And similarly, all these activity, I think I'll also keep my database. I'm keeping database of stroke, but now I will also keep database of mechanical thrombectomy. But congratulations, it was very high standard education program. And I must admit, I also learned few points I have noted down in my diary to practice. And sincerely thank even my own Amit Kulkarni for educating me, in addition to Vikram and Raghunanda and everybody. Thank you so much. So nice of you for asking me to say a few words. Thank you. Yes, and in the evening, I'm attending Guru Prasad program. I'm attending in the evening. He's asking me to connect through DBS, so I'm attending that. Yeah, 7 p.m.
Thanks a lot for joining, sir. Thanks a lot for joining us.
Yeah.
Good. As
my privilege. My privilege.
We are chairing the session.
As we are running out of time, may I request Professor J.B. Agadi, founder trustee of Karnataka Stroke Foundation, Bangalore, to propose the vote of thanks.
Thank you, Dr. Sharma. At the outset, let me congratulate Dr. Vikram Huded for having taken the initiative for rekindling the awareness about mechanical thrombectomy among the practicing neurologists of Karnataka state. It has become the standard practice in a few centers like Apollo Hospital, Narayana Hrudayalaya, St. John's Medical College Hospital, to name a few institutions from Bangalore. When you have a thorn in the foot, do you take painkillers to bring down the pain, or you will pull out the thorn? All of us have experienced the fact that pulling out the thorn brings out instantaneous relief from pain. A similar logic can be applied to ischemic stroke. It is simple logic that in an ischemic stroke, the best way to treat ischemic stroke is to re-establish cerebral blood flow as early as possible. Thrombolytic therapy and best medical management have their own limitations. A lot of public awareness programs have been taking place to bring awareness in general public about the symptoms of stroke, like Be Fast. More than 20% of strokes are due to large vessel occlusion, which may not budge to thrombolysis alone. Thrombolytics work within a time window in a select group of patients. Globally, each year strokes affect around 16 million people and kill an estimated 5.7 million people. In 2015, mechanical thrombectomy was definitely proven to be enormously beneficial in reversing stroke disability and become standard of care for stroke patients with blockage of one of the large vessels. It is estimated that less than 10% of eligible stroke patients are treated with mechanical thrombectomy. In order to maximize access to thrombectomy for a large number of eligible patients, I think it has become the commitment of Karnataka Stroke Foundation to partner with our physicians, medical college hospitals, all corporate hospitals, several non-profitable medical societies, and industry collaborators. Karnataka Stroke Foundation should achieve their initiative by focusing on efforts to improve public awareness for stroke symptoms, supporting legislation to encourage rapid triage of stroke patients, establishing financial incentives to improve interventional stroke treatment. You are aware of the fact that 15th May is officially designated as World Stroke Thrombectomy Day. My congratulations to Dr. Dilip Yagal for his initiative of Mission Thrombectomy 2020 Plus. Sir, you spoke about this in our national conference in February 2021. I think he has left the forum now. Many thanks to Society of Vascular and Interventional Neurology. I'll be failing in my duties if I do not appreciate the efforts of Dr. Suryanarayan Sharma, who has planned this program. As usual, all our speakers, Dr. Amit Kulkarni, Dr. Savit Kumar, Dr. Argundan Nadik, and Vikram Huded have made an excellent presentation. Thanks to Dr. G.T. Subhash for his, he could not join us today, but indirectly he has extended unconditional support to such type of activities. I thank every one of you who have joined us in this program. At the beginning of the program, there were more than 40 delegates, but now I see only 17 of them. Whatever may be, my special thanks to them also. I conclude by saying, long live Mission Thrombectomy 2020 Plus, and let it reach many patients. Thank you so much.
Vidya Dadati Vinayam, knowledge brings humility, is the tagline of Karnataka Stroke Foundation. With this, we conclude today's event, and thank you one and all for participating in this World Stroke Mechanical Thrombectomy Day.